Hello.
Hello, hi Dr. Purvi.
Hi, Dr. Sanjay. How are you?
Hello, I'm fine. Hi Dr. Bansi. Dr.
Hi,
Bansi.
Dr. Banchi, sir. How are you?
All good, all good. How are you?
All set?
All set, all set.
Great.
Hello, Dr. Bansi sir. How are you?
All good, sir. All good. How are you?
I'm fine, sir. Finished with festival season now. Back to work.
Doc, which festival are you talking about?
Last weekend. The weekend was the Shankaranti, right? So
Ah,
that's,
correct.
yeah, not much, but literally all 3 days and a weekend lockdown, nothing was working. So Friday,
Nice.
Saturday, Friday, Saturday, Sunday was literally off.
Okay. So the plan is that we'll go live at about 6:55.
Okay.
Um, we could start with the prayer now and then 6:55 the introductions and then the chairpersons
Okay,
will
right.
take over. They will introduce and that will be the beginning of the
Right.
symposium.
Okay. As you wish.
Hi, evening everyone.
Hi, Manoj. Good evening.
Hey, Sanjay.
Hi, good evening.
With Bansi,
Hi, Dr.
with
Amit.
Payal.
Hello, hello.
Hello, sir.
Hi,
Dr.
Payal. How are you?
I'm good, sir. How are you?
Good, good, good. Sanjay, I believe you're showing actually the boiling process and you kept a boiler to show us how it was done.
I can't show that. I was just thinking, how many of you had injection room posting? It went back to injection room posting. I had to do some homework. Which was first, the syringe or the needle? Which was first, the egg or the hen? Or the chicken or the egg? So the story is like this. So we'll go from there. Which came in first, the syringe or the needle?
Injection room posting is interesting. No, I don't think we had that
No,
something
no.
like
So probably a little. I used to stay in Ballari Medical College for 15 days. We used to
Hmm.
have injection room postings. This I don't remember. It was in the final year or sometime even during house surgency we were posted there. And the only job was to give injections. You would get how many syringes you would break. Put your finger into the. You take the forceps and the water is boiling. You catch the
Uh,
syringe. It is so
Interesting.
burns your hand. And imagine how many abscesses you would see back. I don't know. And you don't know. You learn it from the sisters. Nobody's going to come and teach you the technique like this. And there's no mannequins at that time. Just direct first. Your first shot is a
Hi,
guinea
hi,
pig.
Bansi. Hi,
Hello,
Dr.
boss.
N.K.
How are
Singh.
you?
Ah,
Sheetal,
yeah.
hi.
Morning.
Manoj, I have seen that actually he has written me mail also before that they are
Huh.
planning to do everything online and probably they will shift it to the April.
Everything offline, Bansi. Tera
Ah,
online.
I mean, sorry, everything will be offline. I'm sorry for that.
So, ठीक है ना, good. Barcelona जाएंगे.
Chalo, anything.
For the European Union, EST is in
Actually,
Barcelona.
No, ATTD just got postponed from
Okay.
March to April. And
Okay. It's in Barcelona.
now they've just shifted. It was in Paris, they shifted to Barcelona.
Okay.
Okay. Purvi, are we good to start whatever you had in mind?
Yeah, I think we are good to start. Anjali has already briefed the host, so can
Payal,
we
you'll
have
have to
the
come closer. Yeah. Okay.
yes,
Otherwise,
just to begin on an auspicious note, can we have the Ganesh Vandana, please?
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
Manoj, we are live now.
Right. So we welcome everyone again back for this session and hand it to our master of ceremony today, who's going to take it from here, Dr. Vial Gupta. Vial's done her MBBS and PG diploma diabetology and is a consultant diabetologist in Mumbai. And she's going to be getting things started for us this evening. Over to you, Vial.
Good evening, all, and a very warm welcome to all the esteemed faculty members and the delegates. It gives me immense pleasure to welcome you all on behalf of the Mumbai Diabetes Care Foundation. So today we are having the second session of the symposium, which started last week on the 11th of Jan, which marked a very significant day, indicating the completion of 100 years of insulin usage. So the first insulin injection was given on the 11th of January, 1922 to Leonard Thompson with pancreatic extract injected by Banting and Best. Although that clinical test had failed because it didn't work out, the patient still showed symptoms of glycosuria, ketoacidosis, and also the subjective symptoms did not improve. On the same month, on the 23rd of Jan, Cobble made another pancreatic extract, which caused improvement in symptoms. So finally, the experiment was successful on the 23rd of Jan, 1922. From that time onwards, we have seen this remarkable journey of insulin, right from the previous human insulins, conventional ones, to the now rapid-acting analogs. And so today we'll be discussing about the journey of insulin over the past 100 years. So the topics that we'll be discussing today are the evolution of insulin injectable devices, which obviously improve the patient compliance and ease of administration to the patients. Also, we will be discussing about the cornerstone of how insulin has been the cornerstone of treatment in gestational diabetes and its use in women specifically. Also, how insulin has been used in COVID times. Now it is very significantly used in the COVID patients, and how Corona has increased the number of diabetic patients immensely. So all these topics will be discussed in detail today. Now I want to extend a warm welcome to our chairpersons, Dr. Amit Rajput and Dr. Sheetal Avarsikar. Dr. Amit Rajput has done his MD Medicine, Diploma Diabetology and MHC Diabetology, and he's a consultant diabetologist and runs a diabetes clinic in Jalgaon. Dr. Sheetal has done MBBS and Diploma Diabetology. She is a consultant diabetologist at the Diabetes Center for Complete Diabetes Care, Kandivali, Mumbai. Very warm welcome to you, to the chairpersons.
Hello.
Thank you.
Hello. I guess we will proceed with the sessions. May I now request Dr. Banshi Sabu to take over? Dr. Banshi is the Chief Diabetologist and Chairman at Diabetes Care and Hormone Clinic at Ahmedabad. He is a current President of AERO, Obesity Society, and a immediate past President of RSSDI. I guess he needs no introduction. So over to you, Dr. Banshi.
Thank you, Amit, for kind words. Thanks, Manoj, Purvi, for giving me an opportunity as we are celebrating 100 years of insulin injection. And from 11 January to 18 January, we had CAP 2 program. So congratulations to Manoj and Purvi and all those who are here. Let me share my slide. Topic given to me is a insulin injection technique and delivery. My slides are visible?
Not
yet.
Sorry, I think something. Let me share this screen again. Okay. Is it now visible?
Yes.
Yes, sir.
Thank you. This is the most common question which we are asking since last 2 years. Is it my slides are visible or am I audible?
I think
Control Shift H. What is how to remove this on the screen? Somebody from the RxTV can help me.
You're doing fine. You're showing it the right
It's
way.
fine, sir.
No, that is fine. But on my
Well, sir,
screen, that hello.
sir, you can use forward arrow, sir.
No, that I know. I'm just telling you. On my screen, they are still, writing like the mute and new share and chat. So how to remove that? You remember that? Control Shift H. No. Okay, no problem. It's okay. Fine. Done. No problem. So once again, Manoj, thank you. The topic given to me is an insulin injection technique and delivery device. But you can understand even after 100 years of insulin discovery, and we started giving injection before almost 100 years, but still we have to learn more and more about the insulin injection technique and delivery. And I feel personally also in my clinical practice of last 20-25 years, I feel that most of our patients, even we teach them, we educate them, but many of the times their injection technique and the delivery which they are taking from the devices, still they create a lot of issues. Yesterday only we had seen one patient who was taking injection because his pain was not working, and through 40 IU insulin syringe, he was trying to take the injection from the cartridge of 300 IU, 100 IU per ml. So that was causing the hypoglycemia. So these are the normal problems which we face regularly. And I request all the clinicians who are practicing diabetes, you must tell your patients whenever they are on any injectable therapy, please bring your device, please bring your insulin and take the injection in front of you, so you will know that whether they are taking insulin injection properly or not. With this, I will be talking the first injection insulin given in 1922, how needle is evolved over a period of time, what are the psychological challenges which a person may have because of insulin injection, what are the things which we should educate. The education here I will be limiting only related to insulin injection technique. We will not be talking about the education of a type 1 diabetes or a type 2 diabetic patients. We will be talking about how storage of insulin is to be done, and during travel, how they should take, what are the considerations which they should do it, what are the pre-injection recommendation, the needle length they should know, because we are not actually prescribing. We just write the insulin injection. We don't prescribe the insulin syringe or insulin needle. We are explaining the patient about the insulin injection site, but still, as I told you, a lot of patients, they come back with the lipodystrophy and lipohypertrophy, and we find that they are injecting at the same place. I will be talking something about the technique, and then we will be the insulin injection safety also. But I will be finishing everything in next 20-25 minutes. So slightly be fast, but we will be finishing everything in next 20 to 25 minutes. This we all know. I am sure the last week also I was hearing about this, and just now the chairperson was also talking about that first injection insulin was given to Leonard Thompson. But one very important thing, that the injection which was given to him was the syringe or the needle which they had used, which was primarily designed for IM injection. We know that insulin saved his life is having medicines from Leo and many other people who are living with diabetes. But the injection which was given to him was a that was sort of a very primitive, and the injection was primarily made for a IM injection, but at that time it was the only possible that we had given on 11 January. But the best part is, even after taking the first injection, and he was the first person who was getting the insulin, he survived for a pretty long period of time, even with that sort of a crude injection and the way he was taking the injection also. The evolution of needle, as I told you, in 1924, the first injection, which was the BD was the manufacturer, but before that it was the injection which was taken by Leon Thompson. That was different, but from 1924, the BD is the manufacturing of the insulin syringes, and till 1999, till from that we are using this fine insulin pen needle, which is of 5 mm, which is of 31 gauge and is introduced and providing even greater comfort while eliminating the need for a patient to pinch up and when delivering a subcutaneous injection. So this is what we had in 75 years, almost like we had come out with a very short and very thin needle, which is insulin pen needle of a 5 mm and of a 31 gauge needle also. But then we have also come out with a BD ultra fine nano pen needle. This is the smallest pen needle ever and is provenly clinically effective for patients for all BMI, even for a very young child. Also, you can use the same needle with the same length, and studies had shown that patients prefer for a less pain, for less bruising, and less anxiety also. So this is in 2010, and now almost all of us are using this sort of a pen needle for our patient. But still we have almost 50% of our type 1 diabetic patients, they are still on insulin syringe, and the insulin syringe which we are using is of 6 mm the length of needle, and it is of 30 gauge which we are using in our clinical practice. The FITR guideline is being internationally a guideline which is produced by experts who are all over the world, and they sit and they come out with a FITR guideline, and then FITR guideline had come for India also. I was one of the experts for this FITR guideline to be rolled out across the country. The Sanjay Kalra was the first author for it. There are so many psychological challenges which we know that they are the reason for someone to refuse the insulin. Now, if you see for type 1 diabetic patients, yes, they also refuse the insulin injection, but most of the time the doctor who is treating type 1 diabetes, he is very firm and he knows that if he will not be giving the insulin injection, this child may not survive. So the psychological challenges are both in the type 1 and type 2, in the family, in the caregiver, everywhere. But what we see that most of the time it is the type 2 diabetic patients, they continue to refuse insulin, and many of the times they delay their insulin injection therapy maybe for years for that. The patients to whom insulin injection is advised by the doctor, a patient may refuse insulin therapy. For one, the reason is because it is an injectable. They have to take a fear of needle is always there. But then there are other fear also, like a fear of frustration. They feel that, something which they have done wrong, and that's because now they are on insulin. They have lower self-esteem. They have fear of weight gain. They may feel there is a sense of failure to manage diabetes, as it is a lifelong. Once started, it will be lifelong. They have to take the insulin. But the most important thing is, which I feel they have interference with the quality of life, fear of needle, and third is a sense of failure. So these are the three things which is most commonly our patient may feel for that. So the patient counseling is the most important thing. We have to encourage the decision making with active participation of patients and their caregiver. So we have to explain that, yes, it is the time when you have to start with the patient on the insulin therapy, but that does not mean they will have to be on lifelong. There's a possibility that you have started it for a very short period of time. Somebody is on a steroid, somebody is having some acute problem, some infection is there, and that's the reason you have started for that. The needle fear, you can tell the patient that how small the size of the needle, and that itself by showing it or by injecting in front of you, the patient first injection is still the fear of needle may go away. The interference with the quality of life, that what type of insulin which you are writing, with the pain, with the premix insulin. So that will also tell that how, it is not going to change your quality of life with that. So, these are some of the things which we can always discuss when we are starting the patients on insulin. So we have to educate, but what exactly we have to educate? It is to be educated related to the insulin injection only. We are not talking about the education of every aspect of the diabetes, because education is a key element of therapy for diabetic patients. But here multiple things are to be educated. But when we are talking of the insulin, first and foremost thing which we will be talking, what choice of device will be there, which we are planning to start. What will be the injection design, whether it's a once in a day or multiple times, or it's a twice in a day. What will be the correct insulin injection technique, what length of needle which we are going to use, and the rotation side, the care and self-examination, and which is normally we forget. We may tell the patient that needle length is this, the size, everything, rotation even also be explained, but we forget to tell the patient there is a self-examination of injection site. The injection complications, can be prevented, detection and management. And this is also many times we don't explain the patient that what could be the complications of the injection when they are taking the injection, whether it can lead to some sort of a reaction, local reaction, or there could be lipo and hypertrophy. after long-term uses of insulin at the same place. The safe disposal of sharps and a clinical waste, and this is something which I think most of the clinicians, they just forget. We don't talk to the patient that where they have to dispose their needles and syringes which are to be disposed, and regularly when they are monitoring their sugar, where they have to dispose their glucose meter strips which they had used. So I mean, this is also very, very important thing which we are completely forgetting for our patient. The prescription, again, we are writing the insulin, but we are not writing the insulin syringe. We are not writing insulin syringe of what company. We are not writing the insulin syringe of what needle length which we are looking for. We are not writing the insulin syringe of 100 IU or 40 IU. And the dosage and administration technique, doses we write always, but the technique which we are explaining the patient, sometimes we should have a video also, which we can give it now with the QR code. It is available. I will again show at the end of my slide presentation that sort of a QR code which we can give to the patient, and they can do on their own to understand what is the administration technique, which they can understand by seeing the video also. The pre-injection recommendation, which includes the insulin storage, the resuspension for those who are on premix insulin, the tips for making injection for less painful, that we must explain the patient, and what are the factors which can affect the insulin absorption too. The insulin storage recommendation is between 15 to 25 degrees centigrade, and we should discard it once it is open. So after within 30 days, if it is not being used, then we should discard. This is the room temperature which we are talking. So insulin, when patient is using, they can use it at the room temperature between 15 to 25 degrees centigrade, and they need not be refrigerated. So that insulin which they are using, they need not to store it in a refrigerator. They can use it. They can keep it in the room temperature only, and the temperature of the room is roughly between 15 to 25 degrees centigrade. Never freeze. So in frozen insulin should be thrown away immediately. That is very, very important. When storing pre-filled insulin syringe, store them with the needle pointing up. Refrigerate currently unused vial and refills. And this is, we must explain, because many of our patients who are buying like 5 cartridges or 5 bulb of insulin, then they have to refrigerate the remaining 4. Once we start with 1, but other 4 are to be refrigerated, but not in freezer. I mean, they have to refrigerate at the temperature of between 3 to 8 degree, not with the minus, or it should not be in the frozen. Check the storage recommendation specific to the insulin formulation according to the manufacturer instruction before they use it, and check the expiry date. Now, this is also very important. Sometimes the patient is buying like 10 vials or 5 vials, and they are forgetting the last vial, the next vial they will be using after 6 months or maybe after 1 year. Some of the patients who are buying the insulin and carrying with them, taking it with them to US or in Middle East country or Africa, and then they are forgetting that the expiry date of that insulin may be after 1 year or maybe after 1.5 years. So never use insulin which is beyond the expiry date, which is already stamped on the vial or pen or cartridge that is supplied by the drug manufacturer. Avoid extreme temperature, which is like direct sunlight, the kitchen, the closed cars, the top of radiation or television, and greenhouses. Now, why I'm putting here is closed cars, because some of the patients who are on multiple daily insulin injection, type 1 diabetic patients or a type 2 diabetic patients, they might be carrying the insulin pen along with them, and they keep it in the car only, and the car is parked somewhere and where the temperature is already more than 45 degree or 40 degree in some part of our country, and then it will not be useful. So, I mean, that's very important, which we must explain them. If they are carrying the insulin along with them, they should keep it the place where the temperature can be between 15 to 25, not like the temperature goes like 35 or 40 like that. Doing injection correctly, the insulin should be stored in a flask with ice. So this is what we can explain them, or in a handbag or in a proper container if the outside temperature is more than 30 degrees. We, in our CDIC project, we had supplied some of these patients handbag where they can keep their insulin, the insulin syringe also, and while in the school, they can take the insulin from this handbag, because they will be keeping the temperature of these handbag less than 30. Mostly it will be less than 15 also. The insulin should never be kept in the glove compartment of a car or left in the locked car with a closed window. When there is no circulation of the air, the temperature inside will increase more than 35 or 40. In an air travel, we have to explain them that it should be kept in the checked-in bag. I mean, not to be kept in the checked-in baggage, while it should be inside the hand baggage only, because if they are going to use in checked-in baggage, then it can have a risk of exposure to extreme temperature. Sometimes it will be too low, or sometimes it will be too high for them. So that's very important. Also, when they are air traveling, or when they are taking this insulin outside the country, or they are buying more amount of the insulin along with them. Pen should never be stored with needle, and this is something which is most commonly done. The reason is very simple, that our patients are actually reusing the needle again and again, and we are not explaining the patient that needles is made only to be disposed. Once you had taken, then it should not be reused, but as our patients are reusing it, so they never open it. I mean, once they put it, they will not remove it, even if they want to reuse it, because then warm to cold, it causes compression, and what will happen, the air will be sucked inside. And that's the reason most of the time, and you will see the patient who is coming out with a pain, you will see there are air bubbles which are inside, while when they go from cold to warm, there will be insulin will be out, and there, because of the cold to warm, there will be expansion also. So this is a commonly done mistake, and most of our patients will have, with their insulin pain, there will be a lot of air bubbles, or the air which will be there, and that may be lead reason for them to have incorrect dosing, particularly a patient who is a very young child. When you are giving only 1 or 2 unit or 3 unit, this small amount of air bubble will make a lot of difference for them. Those who can't afford to have a refrigerator, those who don't have the refrigerator in their home, and they are still buying the lot of insulin pen, or they are, I mean, in the insulin cartridge or the bulb, they have to keep it also store in that, and they have to keep it in a, where refrigerator is not available, put the vial in a plastic bag, tie with a rubber band, and keep it in a wide mouth bottle or earthen pitcher filled with water. And this is commonly used in some part of the rural India. Still, they have to take care, and we have to explain those patients to whom we are supporting them. There are underprivileged children to whom we are giving even free insulin. We must tell them where they have to store the insulin. They may not have a refrigerator at their home also. The insulin storage, if it is not used, it should, I mean, if it is in use, then keep it in room temperature. If it is not in use, it can be kept in refrigerator. So all the extra amount of insulin which person is buying, that can be refrigerated. Discard 30 days after initial use. That's very, very important. Avoid freezing. If found frozen, discard it. Store pre-filled insulin syringes, needle pointing up, and avoid extremes of temperature, that is direct sunlight, living in car, on the top of radiator, or as it will make the medication less effective. And these are some of the very, very important points which one should remember. And while educating the patient, we must tell all these points. And something you should write it also on paper, when which person will remember it in much better way. Before injection, make sure that name and type of insulin is properly what you had given. Expiry date is explained to the patient. Whether dispensed insulin is the same as it is prescribed. It is the insulin which is available in some of the store. Just now, before some time, I was seeing they were using the pen of a Lentus insulin, disposable, not disposable pen, the reusable pen, while the person was buying the insulin of a different company, of a basal log, because that was cheaper. So they were, the medical store person was selling the insulin of other company and the pen of other company. So that's a very common mistake which is done by the pharmacist also. Insulin must be clear. There should not be no discoloration or cloudiness or a particle. But the cloudy insulins are those like premix insulin. We have no mix, we have human mixture, we have home insulin 3070. These are the insulin when before using, we have to resuspend it. We have to again make sure that they are properly or uniformly cloudy also. It may be useful for persons with type 1 diabetes to carry a ID card and stating that name of the insulin which person is taking. So if you have a type 1 diabetic patient to whom we have written on a basal bolus insulin, what type of injection which you are writing, please on the ID card, if it is written, it's great, because when they forget to carry the same insulin and they are traveling somewhere and they forget to carry, then they, at least from the ID card, they can get the same insulin also from that. So the correct resuspending insulin for the cloudy, there are still many patients in our country who are on premix insulin. They may be on no mix or they may be on premix human insulin. So they have to make it again. They have to roll out, resuspend it before taking it out from the refrigerator, or even if it is outside also, they should resuspend it, and minimum for 10 times, and do the visual check also for the uniformity of the insulin which is there inside the cartridge or inside the bulb too. The factors which are affecting the insulin absorption is the concentration of insulin. So there are types of insulin which is 40 IU, they might be taking with 100 IU syringe or 100 IU syringe, a 40 IU syringe with the 100 IU per ml bulb or the cartridge. It may create a lot of problems, and then the amount of insulin which they want to inject. Suppose if they are taking with a 40 IU ml syringe and 100 IU cartridge which they have taken, it is 2.5 times insulin actually the patient is taking. The factors which are other than that, which is actually affecting the insulin absorption, is the physical activity and where the person is taking the injection. The injection needle length is also very important, because it is made for subcutaneous injection, and if they are taking it injection with a longer needle, it may go in intramuscular, and intramuscular injection will get absorbed immediately. So even if you have taken a long-acting insulin like a glargine injection, if it is taken intramuscular, it will not be, no more will be a longer-acting basal insulin analog. It may get absorbed in a short period of time, and it may act like a short-acting insulin also. So these are some of the very important issues where, like, immediately after taking the injection, the physical activity, if they are taking a thigh or the place where the muscle is there, and massaging site will absorb the insulin faster, and the needle length is also very important. Other than that, the body temperature, the size of the dose, and the age. If you are taking more amount of the injection, again, like 80 units or 100 units is better to take a concentrated insulin injection rather than going for a dose of 80 units or 60 units with the insulin syringe. So that these are the things also, these are the factors which can also affect the insulin absorption. Now, as we were talking about the needle length, the skin thickness is 2 to 2.5 mm, and this 2 to 2.5 mm thickness is a regardless of age. In an adult, gender, ethnicity, even geographical location or BMI, the most of us, we have the skin thickness is between 2 to 2.5. The subcutaneous fat area comes after that, and then there is a muscle layer which is there. So the right tissue space is a subcutaneous tissue. We have to have a needle which should be more than 2.5 mm. That's very important, and it should be injected in a subcutaneous fat layer, and there we will get a predictable and a very stable absorption. Now, if needle size is big, if it is long enough, it can go directly into the muscle, and IM deposition leads to accelerated absorption, and there will be more possibility of increased risk of hypoglycemia also. So the insulin injection which is made for subcutaneous, if it is given with a longer needle, it will have a IM injection also. IM injection occur more frequently with a longer needle. It will be more frequently with the young patients who are taking on a thigh or on a arms. In male patients because of more muscularity. In patients who inject into limbs rather than on truncal side. So that's the reason we explain the patient to take more on an anterior abdominal wall rather than going for a on limbs. And there is a probability of getting more IM injection if the length of needle is more than 6 mm. So you can see the significant difference between the 6 mm and 8 mm needle size. With the 8 mm, it is 15.3, while it is 5.7% with 6.5. But most of us, we prescribe now 4 mm is a pen needle and 5 mm needle size with the insulin syringe. So this is what is normally prescribed, and the chances of getting IM injection through the insulin injection will be very, very less if you are prescribing a right needle length for that. There is a India ITQ devices use an estimated IM injection risk by the body sites, and here the syringe use continue to be common in our country compared to the rest of the world. Still, we have patients who are using the insulin syringe. As I told you, more than 50% of our patients, rather more than that, who are on insulin injections are still using the syringe and needle. And as I told you, the risk of IM injection will be high with the patients whose length of the needle will be more than 6 mm or 6 mm and 8 mm needle. We had already shown that how much percentage chance will be having the higher chances of IM injection too. So if you
sir,
see
sorry
this,
to interrupt. थोड़ा और फास्ट करना पड़ेगा.
Yes, we will be finishing in next 2-3 minutes.
Yeah.
So 6 mm and 8 mm in the thigh and arm, the risk of IM injection will be very, very high. The new injection delivery needle length, as I told you, it should not be used with the 6 and 8. It is preferably 4 mm and 6 mm, which we are using for our patients. High flow rate, it is extra thin wall of a needle is also important. So if the regular wall, which are some of the Indian companies who are making, in compared to that, the extra thin wall will also make, because it is more appropriate, and with the less force, it can be injectable too. The angle of injection insertion is also important. The shorter the needles, you need not to have a pinch, or you need not to change it to the 45-degree angle. You can straightway go in with 90-degree too. The correct and incorrect way of making the skin fold, there is a video also which we can show the patient. But one very important thing, that making a skin fold, putting the insulin injection directly with the 90-degree, leave the needle in the subcutaneous tissue for 10 seconds and withdraw the needle from the skin, and then you release the skin fold. So I mean, before, if your skin fold is released, then again the possibility that it will go inside the muscles too. The injection site selection is very important. Just to explain the patient that around the abdomen, thigh, buttocks, and arms, which are important site, but it should be rotated, and that's very, very important. The rotation of the site, even at the anterior abdominal wall, still most common in type 1 diabetic patients. One thing which we commonly see is a lipohypertrophy, which is very, very common and which is seen by all the clinicians who are practicing diabetes. The injection technique, the pen, syringe, needle, whichever the way which you want to do. I'm just now, sorry, we are not showing the video. The special consideration for the pregnancy, because pregnant female does not want to take at the anterior abdominal wall. They always feel that because of the pregnancy, they may not able to take. But as I told you, the skin thickness is still 1 to 2 mm, and the needle size of 4 mm will not pierce the fetus or anywhere. It will not go anywhere, but still they can take slightly on the lateral part of it at the instead of taking at the anterior part of the abdominal wall. So that's also one common thing which we can explain to the patient. The needle reuse is a very important. Our patients, they use 61% of the Indian patients don't remember they are being trained on single use of pen needles. Here I will say it's not 61, it is rather more than 90% of Indian patients. They are not told that patients' needle should not be used. The needles which are made, actually it is a disposable. It is to be disposed, and it is not to be reused by the patient. And we should explain our patient very clear cut that this should not be used again and again. Never reuse it because of high risk of transmission of bloodborne disease. But more than that, it will create a multiple other issues, because the needles, when it is used more times, it will become more blunt. It will be causing more pain. Not only pain, it will also have more bleeding, bruising. Lipohypertrophy risk is very, very high, and contamination and infection and dosage inaccuracy will increase. Also, the risk of needle, as it is used more and more, there is a residual insulin which will get crystallized, and that will create the blocking, and patient feel that actually their pain is being wasted. Safe disposal is very important. We should give actually an empty device to the patients, and they can safely dispose it. If they can't dispose it safely, they should bring back the
I think there seems to be a technical glitch. Dr. Sheetal, if
I think, yeah, I think we've lost Bansi, and probably the message by Bansi is already given. We'll take up in the Q&A anything that remains. So if that's okay, we'll wait for Bansi to join in, but we can move with the next talk. The chairpersons, please do that.
Over
his
to you,
screen is
Sheetal.
frozen.
The screen is frozen. There is it. Yeah.
Ritu, please share the slides.
Okay.
You're mute.
Am I audible?
Yes.
Yeah.
Yeah. So firstly, thank you, Dr. Manoj and Dr. Purvi, for inviting me on this platform. So 100 years have passed since the first insulin injection was given, and a lot of progress has been made not only in the producing newer and better insulins, but also insulin delivery devices. So from the times when we used to use glass syringes with whiteboard needles, which were boiled and reused, till today's times with newer pens and closed loop systems, we have come a long way. So to take us through this journey, I invite Dr. Sanjay Reddy for his next talk. Dr. Sanjay is a consultant diabetologist, Center for Diabetes and Endocrine Care in Bangalore, and also Fortis Hospital, Bangalore. He's a principal investigator in multiple trials on diabetes, obesity, and osteoporosis, and he's a vice president of the Primer Academy of Medical Sciences. Over to you, sir.
Thank you, Dr. Sheetal, for those kind words, and thank you, Dr. Purvi and Manoj, my good friends, for inviting me and asking me to share something. And it took me back, let me share my screen, it took me back to my college days.
Sanjay, I'm telling you, Manoj, actually, I finished the talk, but I think last slide I could not.
Yes, sir.
But it's fine. I'm joining again with the mobile, but I am there for the question answer for discussion. No issue. Thank you.
Thank you, sir. Thank you, sir.
Sorry for this.
No, not at all. Not at all. Please. Okay.
You can start.
I can start. Thank you very much, and thank you, Manoj and Purvi, for inviting me to speak on this journey of yours with insulin the last 100 years and what you put this program together. It's lovely to see all of you, and thank you, chairpersons. Thank you, Bansi, for the wonderful introduction to use of insulin, how to take insulin. So what my job is to evolution of insulin delivery devices, boiling water to connecting. Takes back me to my old school day, college medical school days, where we had injection room posting. It was the most dreaded posting. You stand at 8 o'clock and you don't know when you're going to end. And I didn't know how many injections you used to give and how many syringes you had to boil, and accidentally you lift something which is very hot, you drop the syringe, it breaks open, and the matron comes and starts shouting, you doctors don't know how to give injection, and again you get trained by them. Anyway, we come back a long way, and I will stop exactly at 15 minutes. But please stop me at 7:45. I don't want to take much of your time. So, just a history of syringe and needles. Just going back, which came in first? Is the syringe or the needle? It's like the chicken and the egg. So, but here we have a clear answer. It was syringes were invented long before needles. This is from the Greek and the Roman literature. We don't know exact times. The first piston syringes were somewhere discovered, invented by Galen between 129 to 200 CE. It was described by Galen. I'm not sure exactly on the date, but one of the first glass tube for suction of cataract was used by Anwar bin Ali, somewhere in the Middle East. 1650, hydraulics, where modern syringe was the hydraulic modern syringe, which you have where you can push, was invented by Pascal. But the problem with that type of injectable technique was they didn't know sterilization. It caused too many problems. 1844, the first hypodermic needle which was used, and that was by Dr. Francis Ryan at Dublin. 1853 was the first injectable IV insulin given by Alexander Wood at morphine, and 1950 use of plastics and disposables. The reason I went back to seeing this syringes in history is we wanted to talk about insulin use and the syringes, and we've been all talking about how from 1922 insulin was being given, but equally important was the delivery technique and how exactly this has to be given. Look at this. In 1924, it was BD who manufactured the first insulin syringe for insulin injection. Then the first 1925, the first Novo syringe, reusable glass and metal insulin syringe in 1954. And this was a saying in one of the books which is written, that this an anecdote which says a type 1 patient had to take 5 cc at the time. A syringe had only 2 cc, so she had to leave the needle, inject, fill it up again and inject, and it would take 1 hour for her to again walk back to normal. Look at it from last 25 years. The delivery technique has changed, my friends. And how is it? And the first disposable glass syringes appeared called Hypack. That is 1954. First disposable plastic syringes came to market in 60s. Those by 50s they had 54. They started use of plastics. but there are many drawbacks. Now, we know all these drawbacks. We've been through, and those who have been as old as me and 25 years in medical school, by the time you started, you had seen all the type of insulin, all the type of delivery techniques which we've been used to. They were cumbersome, difficult to transport, and it was so painful to take an injection. Inaccuracy in withdrawing the correct dose of insulin, difficulty in mixing insulin wastage, stigma of injection, needle losses, sharpness, more pain. Now, there's a wonderful article written by Dr. Jyoti Dev, Dr. Bansi, and colleagues, published in 1920. I know Dr. Jyoti is listening to this talk. I happened to read this article before I'm giving this talk, and he had put in the same topic, a similar topic, and enumerated the different devices and why there was innovation, need for innovation in insulin deliveries, in insulin devices. The need for devices is equal, the device is equally important as that of the insulin and the technique. I think three things: insulin, the device, and the technique, and education. Four of these things form the right way to take insulin. So we needed them because of all these. We all know these painful things which happen: poor compliance, painful and cumbersome, long needles. We came back from 8 mm needles. You saw Bansi presenting. We had 8 mm needles to now literally 4 mm needles. Probably we go to a point where there could be needleless delivery. Probably that could be a dream. Poor safety for patients, chances of more hypoglycemia, poor glycemic control, and patient dissatisfaction to lesser painful injection, improved compliance to regimes, fewer hypoglycemic episodes, better glycemic control, patient satisfaction, improved quality of life, cost savings, improved convenience, ease of use for the patient and the caregiver. Now, this is the evolution of insulin delivery devices. This from 1922, from the time insulin was discovered, we had innovations in delivery techniques from the insulin syringe from 1924. Then we had the first disposable glass syringe. Then we had the first pump. Then different types of insulin delivery. Is it not? Pump is also part of it, one of the insulin delivery. Introduction of these permanent pens called Novo pen. Then you had insulin Eli Lilly's pens coming in. Then you have manufactured from Sanofi. All of the companies which were manufacturing insulin came out with their individual pens to make sure that the cartridges fit in them. The technique has been the same, but there has been improvement in these techniques over the years to now connecting devices and pens. Pens which can read, which can talk to your cell phone, say whether how much of insulin you're taking, a few words about all of these in the next 10 minutes, 5 or 7 minutes, and then we can end. Now, this is the first pen, the original Novo pen in 1985, first ever insulin pen. It was like, I'd seen people carrying it from across and say, I'm using pen insulin, but we didn't have cartridges. I really don't know when exactly we had cartridges, but the pens were available from 1985. Now you have pens like, these are the different types of pen: Huma pen, Flex pen, Novo pen, Royal, Solar Star. You have pens which can deliver even 0.5 units, especially in children and type 1 diabetes patients. Flex Touch, Insupen, we all have seen these pens. Now, please remember, each pen has to be prescribed with a cartridge which goes with the pen. Please don't mix up cartridges and pens, which is a very good thing. Now we have, and one of the pens to deliver even a GLP-1 analog, which I found very nice, is the recent one, which the dulaglutide, which goes in like, it's like spacecraft. You can't even see the needle. Hope we have pens like that to deliver insulin, so the patient doesn't see the needle, but still can be reused. Then we have two types of pens, the durable and the disposable pens. You all know the durable pens are pens which you can reuse. We have cartridges which we can put in. They are less economic. They are more economical than the disposable pens. The disposable pens you use, especially in short-term use, when you want to initiate insulin, pregnancy patients, patients who are hospitalized for a few days, where you need to give them insulin, patients undergoing surgeries, patients who have difficult handling the cartridges, in reusable pens. These are the people who take disposable pens. But the durable pens, these are all for long-term use, and people some elderly people which come in clinical practice still want to take a vial and the syringe. Please remember, still existing, more than 60% of our patients in our country use syringe and vials. Please use the right vial with the right strength of insulin. Usually, previously we had insulin, which was 40 ml, 40 units per ml and 80 units per ml. Then it got standardized to 40 and 100 IU. Some countries we don't have 40 IU. In our country we have 40 and 100 IU. There's also 500 IU in the US, but 40 and 100 IU. Please make sure that you use the right syringe with the right dosage. And now, with saying this, why I want to repeatedly tell is one of the most important thing is educating. Now, these are connected pens. This is the InPen system. It was approved by FDA in 2016. Now, this has a bolus calculator, real-time insulin on board tracking, dose history. Whenever injected, there's a history how much of dose you were injected. It definitely improves compliance, especially many people. It can you can set reminders. Similarly, you have NovoPen 6 and NovoPen Echo Plus, which automatically record the dose of injection insulin injected, and then data can be shared with collaborating CGM device or into a diabetes management app, or can be shared online to an EMR. I don't know if that is possible. I think that would be the next, if they can talk to your phone, talk to the type of app, and also the EMR. Now, this is what in future you're going to look at. You have connected devices. You can calculate how much of insulin they're taking, when they are taking, how many doses of insulin they miss. I think that improves compliance, and that could be the future. Now, we have this evolution of pumps. This is where we are from a pump with this much, and we've seen these figures over a period of time. From 60s to present day, there's a huge improvement in pumps, and I'm going to just talk a few words, because on paucity of time, we have pumps which are weighing more than 400 grams to now pager-sized pumps, wireless experience, large screen where the displayed information is easy to read. Patient can program several different basal rates to be used in one day to accommodate diurnal changes. Smart pumps, insulin pump that can work along with the continuous glucose monitoring system. So a few words about them. Now you have the pump patch, the Omnipod, which is tubeless, can be worn up to 72 hours. It's controlled by a personal diabetes manager that also functions as a glucose meter. Now we have also the Omnipod Dash. It's an insulin management system, FDA approved in 2018, a tubeless, waterproof, Bluetooth wireless technology pump with a capacity of 200 units of U100 insulin, and updated touchscreen PDM that regulates the pump, and it can be connected to one of the Contour Next One glucose meter. Now, this is automated insulin delivery systems are from a continuous subcutaneous insulin delivery system. We're going to from an open loop, hybrid loop, to a fully automated closed loop system is where we are going. And in the future, I think the future is exciting. If you have the means and the need of all of patients can afford it. Now you have a sensor augmented pump. Here, it combines the CSI delivery and CGM. The CGM data sent wirelessly from the sensor to the pump, which can display glucose values and trends. Insulin delivery is adjusted in response to CGM data. You can do it either manually or you can set it automatically. So this is one.
Sorry to interrupt. We are past 7:45.
45. Yeah, I've just passed. And then you have the hybrid closed loop system, combines user delivery and premier insulin. This MiniMed 760, a fully closed artificial pancreas at a glance. You have a sensor, receiver, a control algorithm, and an insulin pump. So what I want to say is this is one which got the Beta Bionics is the one which got an emergent. It said just put in your weight, we'll take care of the rest. It has both insulin and glucagon. It has a control system, a glucose measurement, and a subcutaneous delivery system. Now, do-it-yourself artificial pancreas. I said we're not going to wait for the results. If the devices are good, we're going to use, and that's the new thing. And then you have an implanted pancreas, which is a fully implanted insulin device. It's a novel AP technology. It's a gel-based one, and the stage of development is not yet. And you have all these apps and how comprehensively all this can be connected, and these devices. Now, we all know from glass syringes to different reasons, and we have come through all this. We have diabetes management systems which are going to change the way you're going to technology, delivery systems. Probably tomorrow, non-injectable delivery technique will come in from the long way ahead from 1924. But remember, the most important thing: you have insulin, you have delivery devices, you have the best insulin, you have delivery and monitoring devices. Until the patient is educated in all of this, I think they will not work well. Thank you very much.
Thank you, sir. Thank you for the excellent session.
Thank you.
I think we are running out of time. I will have one quick question.
Okay.
Dr. Manoj, can we have one question?
Yeah, go ahead,
Yes,
please.
yes, please go ahead.
Is Dr. Banshi here? There was one question for him. I guess
Sanjay will answer it. Jyoti is also there. Just go ahead.
Okay, fine. Some patients
Banshi
complain that when they inject insulin and after they take the needle out, some drops come out. So how one counsel such patients?
The most important thing is to, after injecting, count till 10. What happens is they would have injected and immediately pull out. There's still the delivery is happening. Even before the delivery is happening, you're taking it out. This is one of the most common error which is there. So if you do that, I think.
Sure. At this point, let me take the opportunity to welcome Dr. Vasanth Kumar, President RSSDI. Sir has been kind enough to join us also here, and we welcome him to give his opinion and suggestions as the program moves on today. Welcome, Dr. Vasanth Kumar.
Thank you, Manoj. I'm enjoying the talks.
Good evening, sir.
Thank you.
Good evening to all the faculty who has joined in. Thank you for being there.
Thank you.
Are there any more questions for this injection?
There are no more specific questions. I think we can move ahead.
Okay, fine, great.
Thank you, Dr. Banshi sir and Dr. Sanjay Reddy for those outstanding talks. Very lucid, very comprehensive indeed.
Thank you. Thank you, Dr. Purvi. Thank you, Dr. Manoj.
Thank you. See you guys. Thank you, chairpersons, Dr. Sheetal Avarsekar and Dr. Amit Rajput. We move to the next session and maybe invite the chairs for the next session. Dr. Rahul Dhope and Dr. Anushri Mehta. Rahul is a consulting diabetologist and director of Dhope Diabetes Care and Thyroid Clinic at Pune. Dr. Anushri is a consultant diabetologist at the Kasturba Health Society, Mumbai. Handing it over to both these chairpersons for the next interesting session that we have.
Hello. Yeah. So we have a very eminent speaker for the next session, and I'll quickly move on to introducing him since we're already running late. Dr. Jyoti Dev is an endocrinologist working at Jyoti Dev Diabetes Research Center in Trivandrum. He's the first author for Indian guidelines on vaccination, insulin pump, and glucose monitoring. He's a pioneer in cost-effective treatment of diabetes and use of telemedicine and technology. I don't think he really needs a lot of introduction, and I think Dr. Rahul would like to introduce the topic, and then we can hand over to Dr. Jyoti Dev.
Okay, so Dr. Jyoti Dev is going to speak on insulin use in India. Are we still a premix country? Over to you, Dr. Jyoti Dev.
Thank you. Thank you, Dr. Anushri and Dr. Rakul. And congratulations and thanks again to my dear friend Manoj and Purvi. It's a very unique program, and the title is very, very impressive. The theme is also very impressive.
Sir, I love the background and the frame.
All of you, please keep smiling. The photographs will be taken and it will be in the Kerala newspapers, courtesy Dr.
Manoj, let me ask you a question. What is the duration of my lecture so that I can plan accordingly?
20 minutes at least.
20 minutes. Okay, 20 minutes. So let me share my slides. Actually, I am in the middle of a live program here in television. So I'll be joining back to the channel at 8:05 or so. So thank you very much, Dr. Manoj and Puri. So Manoj has given me the task of discussing the use of insulin in India. And he has also told me that I should be including some cases in between. And I will start with a very typical case. And this is a case of type 1 diabetes, historically very important. I am pretty sure that you're familiar with Leonard Thompson. So we have been listening to Leonard Thompson during the entire month of January, because historically he is the boy who first received insulin. And on the right, we can see the records from the Toronto General Hospital. But what I am going to say, what I am going to discuss tonight is probably different from the usual discussions. Leonard Thompson was a public ward patient. He was admitted as a charity case. And at the time of admission, he was very emaciated. The skin and bones, ketosis, uncontrolled diabetes of more than 600 milligrams per deciliter. And he was given the first dose of injection on the 11th of January, 1922. If you ask me whether it was successful, of course, the glucose dropped, but the ketosis persisted. And he also developed abscess at the site of insulin injections. Collip went on purifying the pancreatic extract. He was restless, and he was successful in another few days in developing an extract which is much more purified than the earlier one. And it was actually much more safer. And this new injection was given on the 23rd of January, 1922. And 23rd of January, 1922 is the day when the first successful insulin injection was delivered. And another injection was delivered the same day in the evening, which resulted in almost 77% reduction in the glucose. And within 24 hours, the boy, Leonard Thompson, looked better, brighter, and felt much stronger. So these are again the records from the same hospital, the Toronto General Hospital. The story continues. On the 15th of May, 1922, Leonard Thompson was discharged from the hospital. But unfortunately, that coincided with the insulin famine, which persisted then. Insulin was no longer available. So when he was discharged from the hospital, he was again back to the original starvation diet. That is the only treatment which was recommended before the discovery of insulin. So he left the hospital with no insulin. He continued with the starvation diet. He again was back to what he used to be in the earlier days, again back to skin and bones. But he was lucky to get readmitted in the same hospital in the October of the same year. And that time he was much more worse. He was in a severe acidosis. He was almost in a coma, and he was severely dehydrated. But the boy survived. The boy survived. Later on, he joined a job. He could live up to the age of 27 years. How he died is still debatable, whether it was a pneumonia or it was due to a road traffic accident, nobody knows. The boy was diagnosed of type 1 diabetes, and he was given an injection. He was given an injection at the age of 13 years, and he survived with type 1 diabetes for another 13 years. So that is a story of the first injection and who received the first insulin, and that was Leonard Thompson. So let me now move on to some of the numbers, which are the stunning numbers, which we keep on discussing, which we keep on discussing with our colleagues, with our friends, and whenever we are lecturing, whenever we are discussing the necessity of insulinization in our patients, that more than half of those patients with diabetes, they are developing retinopathy, neuropathy, nephropathy. And 1/4 of our patients with diabetes, they develop chronic kidney disease. And according to you and me, chronic kidney disease is the most dreaded complication of diabetes, most dreaded complication of diabetes. And that is the costliest complication of diabetes. And these are all preventable, avoidable complications of diabetes. And we do have all the weapons with us. Still, we are losing the battle. Not even 20% are reaching the targets. More than 80 or 85 for all realistic reasons. It makes sense that 4 in 5 people with diabetes are uncontrolled. They are not reaching the targets of therapy. And even a layman, everyone knows the significance of reducing the glucose. If you are successful in reducing the hemoglobin A1C by 1%, you are reducing the chances of a lower extremity amputation by 43%. And we do have numbers. We do have numbers for all such complications. There is no dearth of evidence. We do have the comparative statistics with the available therapies, with the oral agents, with the injectables. Yes, insulin, which was discovered 100 years ago, is still the mainstay. It is still the treatment for diabetes, which has the maximal potential for lowering the hemoglobin A1C. And when you compare the different formulations available in our country, pre-mix, that is 30/70, which is a mixture of a long-acting and a rapid-acting or a short-acting insulin. These are the formulations where the glucose lowering is maximal when compared to any other insulin formulation. So these are a couple of beautiful girls from all across the country. So they come from north, east, west, south. So wherever they are located, wherever we are located, we can be from Delhi, from Punjab or Gujarat or from Mumbai or from Trivandrum, but 70% of energy intake in Indians, it comes from carbohydrate. And this is in contrast to 40% carb in the Caucasian population. So this is something which is true. And this is existing for many years. And of course, urbanization and the transformation in our culture, all of these could have added on to the existing hike in the carb intake. But this is the reality in our country. This is the reality which need to be considered. This very high intake of carb need to be considered whenever a responsible physician is making a prescription of insulin to our patients. More than 50%. So when you are considering 24 hours in a day, more than 50% of which is spent in the postprandial state means when you are ordering a prescription, the prescription should be addressing not only the fasting, not only the preprandial, but postprandial is a major component. Major component because more than 50% contribution in India comes from postprandial. And that is a true Asian picture. Of course, I know that this is going to be a repetition for many of you. The Monier et al., the studies we have been discussing for the past more than 10 years. But remember, even when the glucose is controlled, or even when the glucose is very high at an A1C of 12%, when we say that fasting need to be addressed first when the glucose is uncontrolled, still look at the contribution from the postprandial, and that is the blue colored bars over there. The blue colored bars are significant irrespective of the glucose levels. So across all the levels of hemoglobin A1C depicted in the picture over there, the cartoon over there, whatever be the hemoglobin A1C, there is a substantial contribution in the Indian patient. This is in contrast to the Caucasian. The South Asians, in contrast to the Monier data in the Caucasian population, the contribution from the postprandial remains significant. That is probably one reason in a prospective validation survey, the physicians have made a remark when they were asked the preferred insulin when the oral agents fail in India. More than 61% responded that it will be Idagas, that is Rizodac. That is the preferred insulin to be initiated as well as to be intensified in the Indian scenario. Let me now move on to the second history. And this is again a real life story. So I have begun with the story of a type 1, and this is my own patient. And this happens to be a modern medicine doctor who consulted me long ago, 11 years ago, when the patient was 55 years old. Yes, he was 55 years old. And he was at that time having a type 2 diabetes of 6 years duration on metformin and glibenclamide with a hemoglobin A1C of 10.5%. I spent 1 hour with him. I still remember. I have spent 1 hour with, because I knew him for many years, very senior. I spent 1 hour with him and I explained about what diabetes is, what are the implications of diabetes, what is the importance of preventing complications, because all the lab parameters were normal except for the high hemoglobin A1C. And we gave a prescription of the best available premix insulin, gliptin, metformin, and I added statins and ARBs. And he appeared to be happy, but I found that he was not that convinced. So I asked my diabetes educator, dietitian, and the nurse, and they spent another 1.5 hours with him on how to monitor the glucose, on how to report via telemedicine. We offered free telemedicine follow-up twice a week. And we tried contacting him after we left. Many times we tried contacting him. There was no response. I remember talking to him 2 or 3 times later on, and he was telling me that he is extremely busy and he cannot start insulin. And when repeatedly asking, he said that he is still afraid of hypoglycemia, which is so common with insulin. Why I am presenting this case today? Because I happened to see him last week, and that was on the 14th of January 2022. After a long, I couldn't even recognize him. I very politely, I asked him, what made you come back, dear sir? And he said, you have told me to start glucose monitoring. You told me to start insulin 11 years ago. I have started insulin recently, but I have started glucose monitoring 4 days ago. And I found that my average glucose is above 250 milligrams per deciliter. So please help me, Jyoti. And in questioning, he told me that he had 2 episodes of an MI, bilateral retinopathy with diminished vision. He has got loss of sensations, both extremities, pedal edema. And for the last 2 months, he was started on dialysis 3 times a week. And this is the story. This is the real story, not of an ordinary layman. This is a story of a modern medicine doctor. So this is happening everywhere to everyone, independent of whether they are educated or not. And similar episodes, I am pretty sure it's happening to all of you. It happens every day in our clinical practice. And hence the message is very simple. Dr. Manoj Chawla, our Dr. Vasanth Kumar sir is here, the president of RSSPI, Dr. Benshi Sabu is here. So all these stalwarts, all of you should continue. Dr. Manoj and the team, you should continue organizing, continuing medical education programs. And that is required. That is required for doctors from all across the specialties, since everyone is practicing, everyone is providing prescriptions for our patients with diabetes. And this is a time when we are having safe medications like Idagas. This is a paper that we have presented at the American Diabetes Association. Dr. Benji is also a co-author, where we have shown in the real world, Idagas not only improves hemoglobin A1C, but it is also an insulin formulation with minimal hypoglycemia. Remember, the doctor was afraid of hypoglycemia. For more than 5 years, formulations such as Idagas is available in our country with minimal hypoglycemia. 92% of the patients achieving customized hemoglobin A1C targets, and with none of them developing an episode of a severe hypoglycemia. Another study evaluating the prescription pattern and the clinical outcomes, and this is in 291 patients, where we have shown, look at the baseline data, the patients on oral agents, patients previously on insulin plus oral agents, and across all the categories, there is a significant improvement in the hemoglobin A1C. So this is a 2-in-1 solution. And this is a solution which is most suited for the Indian scenario. And Idagas is the prudent choice for both once daily and for twice daily premix insulinization. And RSSPI ESC guidelines have also recommended the use of Idagas in those patients who are failing on existing therapies. And when you compare with a basal insulin such as Glargine, what do you mean by total diabetes control? There is a superior hemoglobin A1C reduction, 1.4% with idagasp. There is a superior reduction in the postprandial. But my recommendation is this insulin need to be recommended because apart from efficacy, there is a significantly lower chances of hypoglycemia. In a recent multinational study, this is a rise. India was also part of this study where you can see the A1C reduction in the Indian subgroup, very substantial, a robust reduction across all the countries with the rise reduction. But I am more interested in this data on the resource utilization. What about the resource utilization? The resource utilization is related to the episodes of hypoglycemia. The resource utilization reduction of 61% with rise reduction when compared to the baseline therapy. And this is with self-reported outpatient visits to the hospital. What about self-reported work days which are missed? Very, very pertinent in the Indian scenario. The work days which are lost, 90% reduction with idagasp. So it is a cost-effective solution where you have safety, efficacy, and also reduction in the overall burden and cost. A very recent study, very recent study published in the December of 2021. And this is a landmark SMART study from over 40 centers. So this is a multi-centric study from across the country, a prospective single-arm observational study. More than 1,000 patients were included in the study. And the hemoglobin A1C reduction, look at the hemoglobin A1C reduction, it is almost 2% from 9.5%. So the baseline of 9.5%, and at the end of 12 months, 7.7%. There again, there were no episodes of any serious symptomatic hypoglycemia. So now the question for all of you listening to us, the doctors and the healthcare professionals, where do you start? How do you start? When do you start? Whom do you start? You can start Ryzodec or idagasp in those patients with diabetes uncontrolled on current drugs. And this can be 2 or 3 oral agents. Don't wait. Don't wait by adding more oral agents. That is a crime. You should immediately start them on insulin. Patients who are currently uncontrolled on either a basal insulin or other premix insulins or multiple daily injections. And the patient type is also very important. Apart from above the age of 18 years, elderly, the PK/PD properties of this insulin, though there are 2 components, an ultra long-acting degludec, which is a unique insulin with lower chances of hypoglycemia. When compared to glargine, the nocturnal hypoglycemia is reduced by more than 52% in the devout clinical trial. So in the elderly, it is a preferred formulation. And in the presence of renal and hepatic impairment. In the presence of renal and hepatic impairment, when the PK/PD properties are retained, and in the presence of multiple complications or comorbidities in diabetes, this is the insulin of choice. But if you ask me, and this is my personalized answer, Ryzodec or idagasp is the insulin of choice for all of us dear and near to us, our close relatives and friends, the doctor colleagues. This is the safest, most latest, and the best insulin of choice in India. And if you have any question on titration, it is easy to titrate. Our Manoj Chawda is there, and he is co-authoring this consensus on insulin dose and titration algorithm, and he will answer to your questions. It is very easy to titrate the dose. You go by the pre-dinner and you can go by the fasting. But remember, once in a while, please measure the postprandial glucose as well. So we have been discussing about the evolution of insulin. And in the previous talk, Sanjay was discussing about the evolution of insulin delivery devices. In India, we are very, very fortunate to have the old, very old, and the new, and even the newest formulations and devices. And please remember, for the eligible patients, for the affordable and eligible patients, provide them the best formulation which is available. In a country where there is a high carb diet resulting in significantly high PPG levels, Idagasp is the choice as an insulin for initiation and for intensification. And this is the insulin which is going to offer a total protection. And this is my last slide, reminding all my colleagues and friends that IJDT, the International Journal of Diabetes and Technology, published by Walters Kluwer, the submission site is open and you can definitely submit your original research reviews and case reports. So thank you again, Dr. Manoj, Purvi and the team for giving me this opportunity and for the patient listening.
Thank you, Dr. Jyotidev, for that outstanding lecture. And we really enjoyed that. You discussed so many clinical nuances, and that was very, very helpful. So, chairpersons, do we have any questions? We can take a quick question.
Yeah, so there's actually a question from one of the delegates, which is asking about how to initiate Rhizotech, which I think you've already answered. But if you want to throw some more light on that.
Yeah, sure, Anushree. You need to initiate Idagasp when there is an OHA failure. And that is when 2 or 3 oral drugs are failing. And the message is very clear. You should not be waiting for another 3 months. Because when you are waiting and watching, you are inviting complications of diabetes. And when a GLP-1 or a basal insulin is failing, then again, you have to add another therapy. You should not be waiting. For GLP-1, it can be an add-on therapy. When the Rhizotech is added, you can still continue a GLP-1.
Quick question, persons, can I ask, Jyoti, is it really important to choose the largest meal, or it doesn't matter for Idagasp? Just choose one meal which is convenient and start with the dosage that you have in mind.
I agree with you, Manoj, because it is usually difficult to identify the largest meal of the day, and it makes things more complicated. So it is better to start as usual before the breakfast and then keep on monitoring the glucose. And we start before breakfast, and then many a time we start before dinner as well, almost same as Novomix. I think that is more practical because it is very difficult. And the CGM studies in India have also shown that maybe because of the circadian rhythm, the peak is always higher after the breakfast. And I'm sure that Dr. Manoj and Benchibai is also there. All of you will agree with me. The peak is usually higher after breakfast.
Absolutely.
Jyoti, one more thing. I mean, Manoj, if you have, can I ask?
Yes.
Jyoti, is there any study where the Rhizotech once in a day is also given with the flexibility? Like suppose you have started a patient with the biggest meal of the day, considering it lunch, and we have started with before lunch. Now, patient sometimes is taking big dinner. So other day, instead of taking it before lunch, taking it before dinner. I mean, because one side of the portion, the longer portion of it, 70% of it is a long acting and 30% is a short acting, which is going to cover your biggest meal of the day. So, I mean, is there any study? Because we have done it for our patients, to giving him a dose of Rhizotech once in a day, like suppose 20 minutes before breakfast, every day, considering that that's the biggest meal of the day. But we allow the patient that you can decide only one meal of the day, which will be biggest. On that particular day, when somebody has invited you or you are going to go outside, you are going to eat outside for a marriage function or maybe for other thing. Instead of taking on that day before breakfast, you take it before dinner. Or next day again, you can do it again before breakfast. So is there any study such that? I have done with the AZP also, with continuous glucose monitoring, and it had shown a good result. You know, some day it was done before breakfast, some day it is taken before lunch, some day it is taken before. So we have given with the biggest meal of the day, and that biggest meal can be decided by the patient. Yes, it is more confusing. It is only for very highly educated patient, and if they can monitor self.
Absolutely. Benchibai, you are right. In highly educated patients, this can be the role. They can, because the degludec component is flexible, and the interval can be from 8 hours to 40 hours. So definitely you can give before breakfast, another day can be before lunch. And this is similar to 2 patterns in an insulin pump, where at the touch of a button, you can change from a basal pattern to another basal pattern.
Exactly,
So
very
it's
true.
applicable only in highly educated patients. But
Now,
very
Manoj, if you have also the similar type of
So I
patient, or
haven't
Sunil or
tried that,
Jyoti,
Bansi.
we all can write down some patients for doing this.
I think it's interesting. As long as the patient understands you're having a conversation, the patient is smart enough to understand this. I think it could work. So Rhizotec is very
Why
often
it should
used
not work?
twice
There
a
is
day.
no reason. And we have done even some of the patient even with AZP also. And we
Yeah.
found that it is working absolutely well controlled.
Absolutely interesting. Yeah, I think so. It's worth trying in patients who are smart enough to do that and manage it on their own.
Exactly.
Bansi
Yes,
bhai,
Sunil.
one of the new area I feel we are listening on, and it is very interesting. And I'm sure that those who are on the shift duties, especially in railways or either mines, a lot of mines around Nagpur and some states in Chhattisgarh. So those are on shift duties. It will be very much applicable for them if you explain them like this. So it's a new thing which we have heard. Of course, we have got some data on Degludec where you have all these things available, but not with the Rhizotec. So good concept. Thank you.
Here we have our first research study together then.
Yes.
Yes, we can certainly do that.
Thank you, Dr. Jyoti. We are holding him back from his appearances on Kerala and national TV. So, Jyoti, thank you for being with us, and hope that you continue being with us in between your interviews and continue to guide us on today's journey with insulin. Thank you, chairpersons, Dr.
Thank you,
Anuj
Manoj.
and Dr. Rahul
Thank you,
Dope.
sir.
Thank you for
Thank you.
sharing this session. Right? We now move to the panel discussion, and dare I introduce Dr. Purvi Chawla. Purvi is a consultant diabetologist and director of clinical research now at Lina Diabetes Care and Mumbai Diabetes Research Center, and the honorary diabetologist at Mahavir and BSES MG hospitals. Handing it to the moderator for this interesting panel discussion. Purvi,
Hello.
over to you.
Good evening, everyone. Just overwhelmed with the success of last week's sessions and today's. We've had some outstanding talks and discussions, and moving on, we go on to the panel discussion on the evolution of insulin use in pregnancy. And for the same, we have three dynamic experts, three wise men, three men who have expertise across the field or spectrum of diabetes, but remain highly passionate about hyperglycemia in pregnancy as such, which is a very niche area of expertise. So with that, I welcome Dr. Sunil Gupta, sir. He is a physician diabetologist from the lovely city of Nagpur, president of DIPSI or Diabetes in Pregnancy Study Group of India, treasurer of RSSDI, and besides all his academic clinical accomplishments, he remains extremely passionate about patient education through his Hello Diabetes Academia. And besides all the awards that he has received, he's the only diabetologist from India to have received the Outstanding Young Person of the World 2002 award from the US. Welcome, sir. We have another prolific expert, Dr. Anuj Maheshwari, sir, a physician diabetologist and a DMB PhD teacher from BBD University, Lucknow. He is the current National Vice President, RSSDI, Governor of American College of Physicians, Indian Chapter, National Academy Coordinator and Treasurer for the Indian Society of Hypertension. And amongst all his outstanding awards, he has also received the R.G. Wegman Oration from the Indian Society of Hypertension in 2015. With all the orations and awards sir has received, he continues to work to turn things around. Welcome. We also have Dr. A.G. Unnikrishnan, sir, who is an endocrinologist who also wears multiple hats at once. So besides being a practicing endocrinologist and CEO of Chelaram's Diabetes Institute, which we all know is a premier IDF certified institute in education and excellence in diabetes care in Pune. So he heads the clinical care, research, education, and also oversees a philanthropic rural diabetes care program at the institute. Among all his academic, scientific, community, and research activities, They have been well received, and he has been awarded the Subhash Mukherjee Oration Award from the Endocrine Society of India and the Srivastava Award of RSSDI for his contribution to the field of diabetes in India. Welcome, sir, to the panel discussion. And to just move on, because I want you all to get the maximum benefit from this, this trial that we have today. I will move on to the first question, and I would like to bring Dr. Unni Krishnan on the spotlight. So as we understand, sir, insulin has always been the gold standard for treating hyperglycemia in pregnancy until metformin became a popular choice after the results of the MIG trial that had been released. So is this true, and what are your thoughts on the same?
Dr. Unni, audible?
We could not hear anything earlier.
Am I audible?
Yes, you are.
Yes, you are very much
audible.
Yes.
So, so it was after the publication of the MIG study, metformin in pregnancy, gestational diabetes came into light. Now, in the MIG study, the authors, it was a study from Auckland and Australia. They randomly assigned women with gestational diabetes between 20 to 33 weeks of gestation. And the primary outcome of the study was a composite of neonatal hypoglycemia, respiratory distress, need for phototherapy, birth trauma, an ABGAS score which was low, or prematurity. The study showed that in people with women with gestational diabetes, metformin alone or supplemental insulin not associated with any excess perinatal complications as insulin alone, and that women actually preferred metformin as a therapy. So it was after the results of the study that metformin sort of came into its own. And since then, there have been several studies. In fact, the MIG cohort has been followed up into, children have been followed up into their early phases of growth, where they've also shown that the subcutaneous adiposity is higher in children with who are born to mothers taking metformin. The overall adiposity did not change, suggesting that there may be additional benefits of metformin as well. So these were some of the results. And yes, you are right. After the MIG study, metformin for gestational diabetes came into its own. In the UK, metformin is considered to be one of the important treatments for gestational diabetes. In the US, I'm told that insulin is usually preferred. In India, I think we use our judgment and we offer metformin to women unless we think there is a compelling need for insulin in clinical practice that is done. But thank you for the question.
Great, thank you so much for enlightening us on that, because I think that's important from the historical perspective also, that around 2008 when the MIG trial was released, I think metformin did become popular for a while. With that, Dr. Gupta, sir.
Purvi, it is equally important to mention here that we have the Government of India guidelines now for management of GDM, and they have mentioned that after 20 weeks in GDM, you can use metformins in GDM women unless and until it is contraindicated. So like we have UK guidelines which are favoring metformin, like you have US guidelines of favoring insulin. We have Government of India guidelines for management of diabetes in India by Ministry of Health and Family Welfare. And they said 2014 as well as now 18, they have added that it can be the first choice in patient unless it is contraindicated. But of course, there is always an apprehension what Dr. Unni has raised in a very, very subtle way, that there are some trials which have been followed, that MIG-TOFU trial, which is follow-up of these children of the offspring of diabetic GDM mother versus those who are given metformin versus insulin. And now the data is available up to 9 to 11 years also. Earlier it was 4 to 7 years, now 9 to 11 years old children. And they also have to have been found to have increased adiposity, the fat and visceral obesity. So that is what is an apprehension about metformin at this juncture of time. There are also trial on metformin that you have MITI trial. MITI trial is in type 2 diabetics who have been put on metformin and insulin versus insulin alone preconception, and they have been continuous. So GDM is a trial where the key period of up to 8 to 10 weeks of organogenesis was spared. Metformin is given in the third trimester, but here the metformin is there from the period of conception till delivery. And now they have got the outcome data again showing very promising data that it does not cause much of the issues as far as neonatal outcome is concerned. But when you talk about metformin, it also mentions very important MITI trial, type 2 diabetes, metformin with insulin versus insulin alone. Those babies born to metformin group have more number of small for gestational age. So that's another area where possibly we'll have, because everyone should know that metformin crosses the placenta almost up to 50 to 70%. Insulin doesn't cross the placenta. And that's why there is some apprehension raised in last few days.
Great, thank you, sir, for elaborating on the evidence that supports that. And I think so. The theory underlying this entire stand is that metformin does cause a little bit of a micronutrient deficiency intrauterine, and then there is a catch-up growth, so to speak, once the baby is delivered, and that is what leads to.
Purvi, one thing I would like to add here,
Yes, sir,
although
please.
I know that I don't want to go into the detail, otherwise this discussion may go shift to a metformin instead of insulin. But one thing I always appreciate in Indian population, that Indian population which enters into the pregnancy, that is not so much BMI as the BMI was there in the MIC trial. And metformin is against the basic principles of the pregnancy. Because basic principle of the pregnancy is the insulin resistance. Pregnancy is the only condition where insulin resistance is welcome because it is required for the growth of the child which is in the womb. And once we start using the metformin, once we start preventing the insulin resistance since from the beginning, this is against the natural physiology of the pregnancy. What I said 2-3 days before in some other symposium.
I
Also.
heard that, sir. I heard
But
that.
repeated here, but people should also be taking care of this thing in the mind, despite all the arguments which are being given in the favor of the metformin. As Dr. Sunil Gupta said very rightly, after 20 weeks of the pregnancy, we can think of using this up to certain extent if the mother is not so much BMI, so much obese, which kind of the mothers are usually not seen in the India in the pregnancy, in the age group in which they get the pregnant, usually.
So my question to you would be, sir, is insulin really the gold standard now for treating all cases of hyperglycemia and pregnancy? And would you begin insulin therapy for someone who comes to you at whatever gestational age, but with an HbA1c of 5.8%?
For me, or Purvi?
Dr. Maheshwari.
Okay, thank you.
Come back to you, sir.
Thank you, Purvi. I think that every person, if he is having hyperglycemia in the pregnancy, first should be tried for the medical nutrition therapy. If she is not being able to get enough control, desired control on the medical nutrition therapy, insulin should be tried, whatever the HbA1c is there at the entry. Because in gestational diabetes, always you will not get very high HbA1c. You will get HbA1c almost near to the control, but because it is the gestational diabetes, because it is for the pregnancy reason, so you need to control that. And if you are not being able to get it less than 120 by medical nutrition therapy or by doing the diet and exercise, then prandial insulin is the only answer. Gestational diabetes, usually we don't get the fasting hyperglycemia. So mostly we get with the prandial insulin easily. But if we have some component of the fasting hyperglycemia, suppose if person is having insulin resistance, then in that case, we can use the premix insulin in that case to take care of that basal hyperinsulinemia, basal hyperglycemia, whatever is being there. That is my take.
Great. Thank you, sir. Dr. Gupta, would you like to add to that?
Yeah, I feel Purvi, a question is very specific here, addressed that if someone who is already just GDM 5.8, you said HbA1c, so very well controlled, Now, should we be going for insulin versus metformin? I feel this is one of the most difficult question someone asked us. Now, we should know that there are some relative contraindications for metformin. And that is what one thing which everyone should know. So if the person has a past history of any bad obstetric history, some women who has a woman having a small for gestational age baby, some women who has associated vasculopathy, preeclampsia, hypertension, someone who's intolerant to intolerance to metformin. In such individuals, metformin is not a good choice, and I will certainly start them on insulin. Similarly, some women who's being detected in the first trimester at the time of conception, I'll again avoid giving metformin. And even if it is 5.8, I'll start small doses of insulin in such cases. So it has to be clinically, and every time whenever you give metformin, it's better you write a sentence below that you have tried to convince women for insulin. If they're not willing, then that's why you are giving insulin. Of course, the rest of the area has already been discussed, but these are some absolute indications for insulin. Let me share with you. Insulin is the drug of choice in pregnancy, irrespective. Any global guideline you just open and you will see insulin is the drug of choice. Of course, it has to be, of course, of the choice of women. As in big trial, they have shown those are those on metformin, they like the therapy. Naturally, everyone who is being given oral drug, certainly they will like it.
Thank you.
I'd just like to add to that. So the choice between nutrition, metformin, and insulin is basically a clinical one. So instead of going only by the glycemic control level, one could also look at the maternal-fetal characteristics, which will predict. For example, if there is a suspicion of small for gestational age, for example, you could go for insulin therapy, and you might like to relax the goals, because if you aggressively pursue the goal of glucose control, you might cause more small for gestational age. Similarly, when you find, for example, the abdominal circumference is suggesting there is macrosomia, you might like to go for metformin or insulin, maybe both together, and maybe go a little more aggressive on the goals. So depending on that, abdominal circumference or other features of macrosomia, that could be added. Now, the Indian guidelines have endorsed metformin. The UK guidelines also offer metformin, unless, like Dr. Gupta said, there are compelling needs for indications for insulin, like SGA, vasculopathy. But the vast majority of gestational diabetes is predominantly postprandial, and nutritional correction is probably good enough for the majority of women with gestational diabetes. Where in doubt, I think insulin is a drug of choice.
I think
can I ask a question here to the
Yes,
panelists?
please,
Sorry to
please.
intrude. So, great going and all ideal answers, I must say. One of the situations that very often we land up is when the obstetrician or gynecologist is actually asking us to look into the sugars, even if the sugars are not high, but they are noticing some polyhydramnios, some increased liquor, and that is the commonest time that they start getting worried. Do you all face that issue, and should that be a driving force to consider treatment if otherwise you were doing well with medical nutritional therapy and you were hanging in there? Does polyhydramnios increase liquor push us, or should it push us to start insulin or metformin or whatever?
Manoj, that is an area where the role of continuous glucose monitoring actually appears. And it has been already hypothesized long back that if you have got somewhere where you have an apparently everything normal, is still you are getting some unwanted results like polyhydramnios in this case, one should always go for, it could be because of the glycemic variability. This has been hypothesized almost 10 years ago when AGPs and if these things were not available. When our professor Sam GP Moses always used to say, even if someone you feel that this particular case is going little wrong somewhere, start a small dose of insulin, maybe 2 to 2 units of insulin, that will also work. That's what we have learned from our professors. And with all due respect to it, what very rightly Unya said, we should not be just focusing on the glucose or the readings, but also the good communication between the investigation results, the obstetricians findings, and the blood glucose reports all should combine together. Such situation, metformin will possibly not be a good choice, and insulin, maybe a small dose of insulin, see for the glycemic variability, any spikes in between. No one monitors post-dinner blood glucose. Maybe in South India, we have a lot of post-breakfast blood hyperglycemia. Our own data, which is already published in 2 different articles, 2 different papers. And we have shown that it is not the post-breakfast which is highest in Central India, it's the post-dinner which is highest. And no one in our country advocates monitoring post-dinner blood glucose regularly. Occasionally they ask. And if you see post-breakfast 110, post-lunch is 130, and post-dinner 170. Insulin requirement almost get double than the pre-breakfast dose. Someone is on 2, they will say 4, and then possibly it will be 7 or 8, something like this. And this has been documented. So I feel somewhere we are missing out these postprandial spikes, which could be the reason.
Very well said. And I think one important thing that came out was medical nutrition therapy, because a lot of these borderline hyperglycemic cases, I believe at least we have experienced that very well, they can be managed with just medical nutrition therapy alone. Dr. Uni, you were saying something.
Yeah.
Okay, I think Dr. Anuj wants to say something.
No, only you complete, and
I was just trying to say that, one of the things that correlate with polyhydramnios is the maternal BMI. So of course, there are insulin levels are also high in polyhydramnios, suggesting some degree of insulin resistance, but it is a well. So this again highlights the importance of weight control and optimization prior to pregnancy. So that could be an important nuance in preventing these problems, because that pre-pregnancy insulin resistance may be a contributing factor. Just wanted to add that point.
So then only would metformin be better than insulin for such patients?
Well, so when I used to be a professor at the Amrita Institute of Endocrinology, I used to say only insulin. But now that I'm seeing the real world practice, I'm quite pragmatic, and metformin is preferred by a lot of gynecologists, and for good reason. But having said that, like Dr. Gupta said, it's good to weigh the evidence and choose metformin for the routine, young, complication-free, vasculopathy-free gestational diabetes. And wherever in doubt, choose insulin, because that is the treatment of choice, and it always seems to work very well. But yes, metformin definitely I feel has a role, and the UK guidelines endorse, the NICE guidelines do endorse metformin as a initial choice. But yes, I think wherever in doubt, insulin is the go-to drug, and there are several regimens for that, as you know.
Just the irony that, metformin label still doesn't carry the fact that it is approved for pregnancy, use in pregnancy. So I think there is a little bit of a mismatch there, but yeah. Dr. Maheshwari, you were saying something, and then I would also like you to address which insulin regimens you prefer in pregnancy, and should we initiate with basal or premix in pregnancy?
Yes, Purvi. My take on this was that whenever this kind of the situation arises, as Dr. Manoj Chawla was saying, this is mostly, as Dr. Sunil Gupta has already highlighted, this is mostly because of the poor monitoring. And many of the times this poor monitoring is our avoiding tendency also. Sometimes we don't want that patient to be on the insulin, and we keep on understanding that MNT is doing well and MNT is doing well. And we ask the patient to get the fasting and PP. Fasting is already normal, and PP she is doing after a little breakfast, and that is coming normal. And everyone is very happy. Nobody is taking care of that, what is happening after the dinner and after the lunch. So these are the situations because of what these things usually arise. But again, I would like to say that in such situation, metformin again would be not a good thing to start with, because these kinds of the situation again would increase the decrease the insulin resistance, and fetal growth will be jeopardized further. So fetal growth would be the best parameter whether we should start with the metformin or not. Otherwise, if we are not having any information regarding that, better to start with the insulin. Mostly physicians don't have this kind of the information once the patient comes to them. As far as your next part of the question is that which regimen should be preferred. So obviously in gestational diabetes, I prefer the prandial insulin. Mostly prandial insulin works well. Sometimes it works well only with the largest meal. Later on, it works with the more than one meal. Sometimes we just break the breakfast into the two parts, and it works well, keeping the postprandial hyperglycemia up to the desired level in minimum amount of the insulin. But if the person is having little insulin resistance before entering into the pregnancy, or the female is obese, in such situation, we require little bit of the basal insulin also. Then premix works very good in such situation. And many of the times I have tried that in the morning I am giving the premix 50-50, and evening only the prandial insulin is working enough. Or post lunch only the working prandial would be work. Sometimes it also happens that we are giving the 50-50 in the morning, and that is also taking care till the lunch. And in the evening, we shall be requiring only one shot of the prandial insulin, and it is doing good. So that is quite individualized whenever we say which insulin regimen is required and how to give that. That is my take.
Thank you. Thank you so much for elaborating on that. Dr. Gupta, sir, do insulin analogs have a role in controlling blood glucose in pregnancy?
See, when it comes to gestational diabetes, as Unni has already commented, that it is one of the JDM, practically a postprandial hyperglycemic state. You know, you have post breakfast, you have post lunch, and you have post dinner. So it is the postprandial hyperglycemic state. In such situation, best is of course the analogs, because you have aspart available, you have lispro available. These are the only two insulin analogs which are being approved for use in pregnancy. Glulysin is not been approved. Of course, Fiasp is, because aspart is available, so fast acting aspart is also approved. So these are the three rapid acting analogs which actually controls postprandial blood glucose very well in GDM whenever it is required. Then second part of it is, if someone has fasting hyperglycemia, then of course you already have regular insulin can be used, NPH insulin can be used. They are all very much indicated. But when it comes to analogs, you have only Detamir which is being approved for its use. Glargine, there is a new recommendation. Till 2015, Purvi, we had classification of use of drug in pregnancy. It was A, B, C, and the Glargine till that time was in category C drug for use in pregnancy. But after 2015, that classification has been removed, and now they have a individualized. It has been said that FDA USA says that if some particular type 1 or type 2 diabetes already taken Glargine, and if clinician feels that by withdrawing Glargine, the glycemic control may go haywire, and that can affect the fetal outcome, in such situation, for the safety of the patient, Glargine can be continued. Otherwise, one should take aspart or lispro as rapid acting analogs, and Detamir as a long acting analog. There is no safety data available in pregnancy of degludec at this moment of time, and of course Glargine 300 data also not available for safety. Only Glargine 100 data is available. That too is it's not a RCT trial, so there is no randomized control trial of Glargine in pregnancy. Whatever data is a retrospective data and observational studies.
Great, thank you so much. You elaborated quite a bit on that. So the message is very clear as to which insulins are safe and approved for use during pregnancy. Dr. Unni, is there a maximum insulin dose limit during pregnancy, and how do we get past that? I think you partly touched upon it, but if you can clarify that for us.
So I think by far my choice of insulin regimens in pregnancy is Detamir and aspart, and that's because of its very low mitogenic, effects, the ratio, mitogenic to metabolic ratio, or the IGF-1 stimulation is very little these drugs, Therefore, the perceived risk of teratogenicity is low with these drugs. So given the patient is on, say, aspart and detunir, and if the dose keeps going up, you have three choices before you. The first choice is what I like to do is I like to split the detunir into two. So I split the detunir into two because all said and done, detunir acts very well for 12 hours, though it does have an action for 24 hours. So the first thing I do is I try to split it into two. The second clinical aspect I'd like to look into is the possibility of, if the insulin dose keeps going up, I look at what could be the reason for that. Of course, we are all specialists here, so we will look at the insulin technique and the cartridge and the injection and where they have purchased the insulin from. Sometimes, insulin from an online source or not a very reputed source, maybe that insulin quality may not be that good, etc., etc. But beyond that, adding metformin I have found is useful, especially when the insulin dose goes up. And two clinical clues I find to suggest the need for metformin as add-on is that some of the women start complaining of lots of hunger. That's a time I think metformin really works because it reduces the appetite. Second is, with high doses of insulin, there is a specificity spillover syndrome where the IGF-1 receptors in the neck are stimulated and you start getting the acanthosis nigricans color towards the end of pregnancy, which is also worsened by the insulin resistance. These are two clinical clues to suggest that metformin may be added. Third, of course, is the most simple thing to do is to relook at the diet, maybe use CGM, find out the patient herself can find out what dietary changes need to be made and work intensively with the nutritionist. Some of these patients are on daily, on a daily basis, they are in touch with our diabetes educated nutrition. These are some of the things that can be tried in clinical practice. Of course, looking for other endocrine causes, etc., is very rare, but if there are some clinical clues, you could look at them. And of course, other rarer phenomena like insulin resistance, type B syndrome of insulin resistance, insulin anti, these are all extremely rare. Usually, you see this happening in women who are obese and taking a high dose of insulin. Early on, their insulin requirement goes up.
Very comprehensively explained. Thank you so much for that. And we have just like 3 minutes more. So I'm going to request a very quick answer to the next 3 questions. So Dr. Sunil Gupta, sir, where should a pregnant lady inject insulin? They're often afraid of injecting in the abdomen. So that's important too, injection technique.
It's more psychological than the factual. So if they can take insulin anywhere. Of course, when they have psychological issues, then we don't disturb that. And we can ask them to take on thighs, or I'll usually prefer abdomen as thighs, the best one. And then third, of course, is but they can take insulin anywhere they want. And that myth of not taking insulin abdomen, I feel that should be removed from the mind, because the needle which you are using is too small to go anything. But psychologically, they have some this issue. So, but there's no data which say that we should not be taking insulin. And there's a good data what Unni has said, that adding in a metformin to high dose of insulin, there's a good data paper available on these lines. And one rare, and if I don't know, but if you allow me to speak for 30 seconds, we have in 2 or 3 such patients with too much of high dose of insulin. You ask how much is the highest dose, but all of us will say that there is no mathematics involved here. It has to be individualized. They can go to any numbers. I had one patient who was started with 85 units in the initial stages, went up to around 135 units of insulin per day, and she was put on pump. She non-affordable. We took pump on higher in last say around 12 to 14 weeks, and she could do very well in the last 2 to 3 months. So we can take even sometimes help of such pumps, which can allow you to have good glycemic control. And very nicely said by Unni, determine when you require higher dose need to be given twice a day. It will not be able to cover with once a day. It's not sufficient.
Great, thank you, sir. Dr. Unni, that brings me to the final question for you. For type 1 diabetes patients, what do you prefer? I mean, if they can afford and if they monitor well, if everything is optimal, then what is your preference? MDI or multiple daily injection therapy or insulin pump therapy? And why?
I think both Dr. Gupta and Dr. Anuj Maheshwari have talked about the importance of insulin. And wherever a type 1 diabetes enters pregnancy, if I can choose, if cost were not a factor, then I'd certainly prefer an insulin pump with continuous glucose monitoring. But we live in India, where the sheer burden of a disease, the financial burden of a disease like diabetes, can coexist with ground realities such as affordability, accessibility to medicine. So given that situation, we often make do insulin injections, and it's not, we can manage these patients quite reasonably well. But given a choice, yes, insulin pump and continuous glucose monitoring would be what I'd prefer. And we do have such patients who have successfully managed pregnancy with both pump and CGM throughout pregnancy. We've had that many times, type 1 diabetes people.
But there's no role of premix, please. Our delegate type 1 diabetes, please don't use premix.
Very important point.
Yeah,
thank you for
absolutely not. Premix should never be used in type 1 diabetes, as but that goes without saying. I think very important words by Dr. Gupta. Type 1 diabetes, basal bolus is the way to go, and of course insulin pump for the affordable.
Great. I'll have Dr. Maheshwari have the last word here. So what are the risks associated with insulin use during pregnancy? And if you can, I know we discussed, Dr. Gupta also highlighted very well the monitoring, but if you can summarize, the monitoring pattern that we suggest in insulin. I mean, in pregnancy, sorry.
Anuj, you're muted. Anuj, you're muted.
You need to unmute, Dr. Anuj.
Sorry. As far as the risk of insulin is concerned in the pregnancy, I don't find any risk other than if a person is allergic or having some tendency of the lipodystrophy, or somebody is having the hypoglycemia. Hypoglycemia in pregnancy, I do not find a bigger risk, because in normal pregnancy also, some sort of the hypoglycemia keeps on going. And it is not very much different than the hypoglycemia, what we call in non-pregnant diabetic individuals. So many of the times in the pregnancy, in a non-diabetic pregnancy, we see that morning blood sugar level goes up to 55, 60 normally also. So we should not really be very much worrying about the hypoglycemia during the pregnancy. Apart from that, more important is the monitoring part. If we can't do the CGMS kind of the things, if affordability is not so good or availability is not so good, then better we should ask our patient to at least monitor 3 or 4 times in a day. At least all major meals should be covered with the postprandial glucose monitoring, 2 hours postprandial glucose monitoring after the first bite. That is the best policy for taking the patient towards the best outcome. And usually I find it works well.
Thank you so much. This was a brilliant conversation that we had for 30 minutes. And I'm surprised that, as much as you read in this field, you always fall short, and we're always learning more about treating hyperglycemia in pregnancy. So thank you very much, Dr. Sunil Gupta, sir, Dr. Anuj Maheshwari, sir, and Dr. Unnikrishnan, sir, for sharing not only academic and scientific evidences, but also your clinical acumen and experiences. Thank you very much. Very fulfilling session.
Thank you, Purvi and Manoj, for
Wonderful to be here.
Thank you. Thank you.
Wonderful to be here with all of you. Thank you.
Thank you. So we move on from this panel discussion to another great talk and 2 sessions that we have. I know we are running late, but I'm sure all of you will bear with us and enjoy these sessions on this weekday when we are meeting to celebrate the centenary of insulin. So for the next talk, let me invite the 2 young dynamic chairpersons, Dr. Mahendra Patel. Mahendra is a consultant in diabetes at Patel's Diabetes Care Center, Thane, and Dr. Dhananjay Mane, who is also a consultant diabetologist at Mane Hospital and Diabetes Care Center, Bid, Maharashtra. So with this, let me hand it over to the chairpersons to invite the speaker and take this ahead.
I'm very thankful to Dr. Manoj Chawla sir and Purvi Chawla ma'am for inviting me to introduce our eminent speaker of this evening. Dr. Mangesh Tivaskar sir, who is the gold medalist, who is also Honorary General Secretary of National API, ICP, and PRF. He is on editorial board of JAPI Medicine Update. He is the guest editor in various journals, delivered more than 1,000 lectures at the many national and international conferences, and has a multiple chapters, publications, posters, presentation, write-up in the next books. Very warm welcome to the Mangesh Tivaskar sir to this beautiful session. Over to you, sir.
Thank you very much, Dr. Dhananjay. And Purvi and Manoj, I'm really jealous of you guys. Such a wonderful and such a superb program that you have continued. And I'm really failing short of words to appreciate last panel discussion. Sunil, Unni, and Anuj, along with Purvi, did a brilliant job. There are so many questions that I also had, and you technically answered everything. So moving on, as today being the special day, and as Manoj has already talked about, we are celebrating the centenary year. Now, as we know, we have got original insulins to manage our diabetic patients correctly. But we all know that, the innovator insulins or any innovator biologics, if at all we talk about, has some caveats as well. And most of the caveats are usually the availability, cost of the therapy, and maybe possibly, the I would say outreach to the deserving population. And hence, probably the concept of biosimilars have come. So in next 15 minutes time or so, as Manoj has asked me, I'll try and cover what are the basics of biosimilars and what are the things that you're supposed to do when you talk about interchangeability. Are there any laws? What we are supposed to know as far as the biosimilars are concerned. I don't have any disclosures. And in my agenda for today, after a few introductory remarks, I'll just give you biologicals, what are biologicals and why you are supposed to know about them. I'll just give you a bird's eye on that. And then probably open mind thought to biosimilars. Let us have an open mind discussion as far as the biosimilars are concerned, and few carry home messages or carry aboard messages that I'll give. So remember that when any biological or any drug is invented, there are two ways of production of the drugs. Number one are what we call it as a small molecules, or also called as generics, are usually chemical compounds. And the other group are the large molecules, usually called as biologicals, and they are actually derived from the living cells or proteins. Now, there are so many sources of biologics. I'm not going to go to the details about it, but remember that, and especially in the COVID times, we already have realized the importance of biologics. So this is the need of the hour today, and the world is going to need them. And remember that these biologics are the large molecules. They are not only just large molecules, but they are far more complex than the simple chemical structures and chemical pharmaceutical agents that we are supposed to use or we are trained to use. More importantly, they are the need for the treatment of the most difficult conditions or serious conditions like malignancies or autoimmune disorders or some neurological disorders or some hematological challenges. Biologics, and including COVID now, biologics have changed the way we actually look at the pharmacotherapy of these difficult medical conditions. And most importantly, biologics are typically made in the living organisms mainly by what we call it as the genetic engineering or a DNA technology. So these are the typical medicines which are usually grown up from the living cell line. And a cell line is expanded, the cell line is picked up, the cell line is isolated, the DNA is introduced into the cell, and this cell line is expanded into bioreactors and then ultimately gets purified and is available to the world for use. Understand this very intriguing fact that typically from the birth of the idea to the prescription table, it will take around nearly 17 to 15 years for a drug to reach the patient. So from the invention of the concept or the thought of the concept to the inception of the drug, this much period is required. And look at the cost involved, around 150 to 300 million dollars. Very interesting fact, I'll bring it to your notice. If it will not be an exaggeration if I say that it is more difficult and expensive to reach human body than to even reach the outer planet. Remember Mission Mars? It took just 3 years and $70 million. So that is the importance of, I would say, pharmacological research. Now, why the biologics are difficult to produce? Now, you can see on the left side of the screen, look at the small generic chemical molecule of aspirin, which is just 180 Daltons. This is a very typical chemical drug that you are able to see on the screen. But when it comes to a biological, large, nearly around 150,000 Dalton molecule, which has got more than 800 folds, are so difficult to produce. And hence, you need to understand the differences. So overall, biologics per se are classified into two larger groups. Apart from the small chemical molecules that we know about, are usually the intermediate molecules and the large molecules. Intermediate molecules has insulin. They are mostly hormones or growth factors. They are complex and difficult to replicate, but it is not impossible to replicate them. But monoclonal antibodies, which are large, highly complex molecules, are technically impossible to replicate, and you cannot make the biosimilars of these monoclonal antibodies. All the biologics are difficult to copy, but it is not impossible. And remember that there is a method by which the entire copying happens. The challenges for the innovator biologics are usually they have to undergo very tedious DCGI FDA clearance norms. And that is the reason why you have seen that, the concept takes nearly 15 years of investment of nearly $300 million. So they become expensive and not all can afford them. And also requires a very highly sophisticated production and technology, and mostly technology is patented. And that is the reason why biologics need some biosimilars, and especially intermediate biologics. They will definitely, be needed as a biosimilars to make them more affordable. And as the patent expires, probably it also offers a better competition between the various pharmacological industries. So what are biosimilars? They are the biological medicinal products which will contain the same version of an active substance of an already authorized original biological medicinal product, that we always call it as a reference medical product. And this biosimilar word primarily was born from European Medicine Agency, or EMA, as a regulatory term. There are a few other terms, like WHO use it as SBP, that is similar biologic product. US FDA uses as follow-on biologic. Canada uses at SEB, that is subsequent entry biologic. So there are different definitions of these biosimilars. And look at this. The concept was introduced to the world in 2004 from Europe. And in India, it was introduced in 2012. And from that time onwards, India has become one of the global hub for the production of the biosimilars. And India is one of the leading contributors in the biosimilar markets, and more than 50 biopharmaceutical brands are marketed whole over India, and it costs around $220 million. And this is what we know about biosimilars, right? But remember that, and this is a very important slide that I want you people to understand, that biosimilars are not generics. They are different. They are highly complex. The complexity is significant as far as the size, the post-transcriptional modifications, the flood patterns, the antigenic drift, everything occurs to the biosimilar. So they are different from generics. They cannot be classified as generics. So biosimilar in nutshell are different from the wholesale series of the innovators. Remember that. But most importantly, manufacturing expertise is needed. And even though it is different, but still, even the cell line is different from the innovators, but still the expertise is needed. There can be a batch to batch variability, but that can be even with the innovator biologics. And understandably, innovators always have a tendency to keep their recipes in a lock and key, secret recipes of the innovators, naturally. And hence, sometimes biosimilars can have immunogenicity. And there are few causes for the immunogenicity. And that is the reason why biosimilars need to prove their safety. And hence, a robust pharmacovigilance is needed when you talk about biosimilars. Now, why we need biosimilars? I've already discussed that these are affordable molecules. They bring down the cost, and the approval process is much faster. Now, look at this. As the patents expire, naturally the competition for getting the biosimilar comes into. And remember that the production process, even though it is almost similar, but the post-production approvals are much less expensive and much more quicker. Now, why this happens? Because you can see that a reference biologic or an innovator biologic, there is a huge methodology of developing the product, right from the molecular characterization to the preclinical trial to phase 1, phase 2, phase 3, and then the post-marketing surveillance happens. All that can be bypassed when you are manufacturing a biosimilar. And what you are supposed to do are to have a few around, say, phase 3 clinical trials or a phase 4 clinical trials, but you need to have a robust technique of developing a molecular characterization, And then the post-marketing survey, or what we call it as a pharmacological vigilance or a pharma vigilance, is mandatory. Always remember that all biosimilars need to satisfy the extensive analytical characterization that is usually a character of the production of any biologic, no matter it could be an innovator biologic or a biosimilar biologic. And that is the reason why, being in India, we have a huge human resource to come up with the biosimilars that we have, and especially insulins. Now, this is what the cost-effective production of biosimilar is, that you do not require any animal studies. You do not require any phase 2, phase 3, phase 1, phase 2 studies. Phase 3 studies are only really needed to just prove the non-inferiority of the product to the innovator biologics. Preclinical studies are not necessary, and they are not so robust as innovators. Approval process is relatively simpler, and most importantly, they do not require too many clearances, and that offers a better competition. And this is what the paper, which was published by Dr. Sanjay Kalra and team from the Sears group of the people, and they have clearly told us what biosimilars should satisfy and what is the switch of biosimilars. Interestingly, a very simple and a beautiful thing which has come up in a quest to develop biosimilar in one of the monoclonal antibodies, that when they were working on with infliximab, which is a monoclonal antibody used to treat the rheumatoid diseases or an arthritis type of a diseases or autoimmune diseases, they actually created a better product which is much better, and these are called as biosuperiors or bio-betters. Now remember that. Or a filgrastim was worked, and then during the working of biosimilar of filgrastim, they ended up finding out pegfilgrastim. Remember that if there is a bio-better production, all the similar laws and the approval processes are needed similar to the innovator biologics. There are few biomimics where in the countries where you do not have a very stringent approval mechanisms, you get something called as biomimics or biocopies. They are not as stronger biosimilars as, because you can see that high quality biosimilars need to satisfy nearly 95 similar attributes, where a low quality biosimilar, or what we call it as biological copies or biomimics, they do not require so much of attributes, and they require just 87 attributes in the acceptable things. In the last 2 or 3 minutes, I'll talk about biosimilar insulins, especially in the Indian context, and the Biocon insulin that we have, because Biocon being the educational partner for this session, I'll talk about their insulin. As the manufacturing is complex with the biologics, same way insulin manufacturing is also not easy, and it's a very complex procedure. And remember that the cell lines which are used for the production are usually either yeasts or E. coli bacteria, which are usually processed, and then you get a biosimilar or an innovator biologic. Now, whenever you talk about the biosimilar, the question of immunogenicity and effectivity is always asked. And that is the reason why this very interesting poster, which was published in IDF in 2015, brought or caught my attention. And you can see that in comparison to the innovator Lantus insulin, look at the immunogenicity of Glaritus as well as Basaloc. You can clearly see that Lantus and Basaloc technically go hand in hand as far as an immunogenicity is concerned. And Biocon's insulin has also conducted the global phase 3 trials on various groups of the diabetes patients. And also they have conducted the trial, which is called as InStride 1, 2, and 3, where they are not only looked at the effectivity of this biosimilar glargine of Biocon in the type 1 diabetic patients, type 2 diabetic patients, and they also have looked at some patients where the switch was done from the innovator biologic insulin to the biosimilar insulin of Biocon. And what they found out, that as far as the glycemic control is concerned, it was almost no difference observed. As actual over the period dose required was concerned, it was not different than the innovator insulin. All time or nocturnal hypoglycemia was concerned, it was almost similar to the original insulin. And most importantly, when they did a switch from the innovator insulin to the biosimilar, they found out that there was not too much of immunogenicity challenge. The safety, the efficacy, the characterization remained almost similar to an innovator insulin. Lastly, talking about substitution, are there any laws? Yes, remember that we being in India practicing, there are very clear laws of what we call it as an interchangeability or switch. always instruct your pharmacist that they should not switch or interchange the insulin brands or any intermediate biologics brand to the biosimilars if at all they are available. There has to be a clear instruction to the pharmacologist or a pharmacist on that. And remember that the prescriber should be able to prevent the substitution. So it is your job to prevent the substitution by writing down dispense as written or brand medically necessary. Prescriber should be notified by the pharmacist about the switch if at all it is happening, and simultaneously it is your job and the pharmacist's job to inform patients also that they are doing a switch for whatever the best possible understood reasons. So friends, to summarize, I would say biologics are the need of the hour. The process is complex and requires a huge amount of investment, time, and expertise. Biosimilars have, especially when it comes to the intermediate molecular biologics, I can tell you that biosimilars have offered a more affordable choice and giving a drug which is almost identical, not even though similar, I would not say, but nearly identical to the innovator biologics. Biosimilar approvals, they are easier, they are cheaper, and hence biosimilars, they become much cost-effective options for the therapies, especially in those class of patients where we have a huge load of diabetic patients. And we being in India, we are all low socioeconomic status, where our authorities, our governments do not invest too much in the healthcare sector, probably. And when the healthcare sector is actually dealt by the patients and they pay from the pocket, it becomes imperative to address the cost as a challenge. And hence, I appreciate Bansi and the team when they have for the first time appreciate the cost factor and included that in the RSSDI diabetes management guidelines, where they said that cost is one of the biggest thing that has to be considered whenever you are offering any kind of the glycemic lowering therapies or any medical therapies to the patients. And hence, physicians, patients should have a choice, and their decision has to be critically taken when they want to prescribe biosimilars and while making the use of biosimilars in the process. Thank you very much. I wish you all a very, very happy and a prosperous new year and a very happy festive season. Purvi, Manoj, you guys have rocked today, and I'm very happy to see Dr. Beni madam as well. Good evening, madam.
Thank you. Good evening. Wonderful talk.
Mangesh, thank you. I think great talk, clearing up any kind of confusion, if at all, on the biosimilars. There have been questions coming, and I'm sure the chairpersons are also checking on the link for the questions from delegates. There is one question, not directly linked to this necessary, but I thought Mangesh would be the right person to answer. Somebody is asking a question on quality of insulins and can insulin be arrhythmogenic?
Arrhythmogenic. Insulin can be only arrhythmogenic when probably there are two ways by which it can trigger hypoglycemia, and that subtle hypoglycemia has presented as an arrhythmogenic trigger to the patient, especially to the vulnerable class of the patient. So you may not say that actually the insulin as a molecule is arrhythmogenic. And always remember that we naturally produced insulin in the beta cells. So how a naturally produced product can be arrhythmogenic, if at all, we need to understand. But the only arrhythmogenicity can be because of the possible hypoglycemia. And if suppose somebody has insulin sensitivity, these are the only two patients, class of the patients where you should be a little more careful.
Sure, thanks. Mahendra?
Yeah, this was a nice talk by Dr. Tivaskar. I think so we should go ahead with further talks.
Thank you, Mahendra bhai, and I appreciate it. Thank you.
Thank you, Dr. Tivaskar, once again. You are truly a great multitasker. I don't know how you managed to give so many talks on such a variety of topics in medicine. So thank you again for gracing this symposia and for being with us. Thank you so much.
Thank you. You've been always sweet to me. Thank you very much.
Thank you, chairpersons, Dr. Dhananjay and Dr. Mahendra Patel. Thank you for chairing this session. We move to the final session. This is one of the clinically most relevant sessions, and we all have been waiting for this. We have three stalwarts who are joining us for this session. The person championing the cause of women's health and women and diabetes. It's an honor to have Dr. Beni Neglur with us this evening. Dr. N.K. Singh, who has extreme passion for education and has made sure that all of us are also kept updated with all the information on the various CME groups and the great passion for updating knowledge and speaking the same is something that Dr. N.K. Singh comes with. And then finally, we'll have Dr. Samit Ghosal, who's an elusive friend. So we're fortunate to have caught him somewhere in the jungles of Bengal and somewhere in the east part of the country and getting him here today. And then I'm sure all of you will know why it's difficult to get him, and it's so worth getting him for that last talk that we have today. So pardon my intrusion into this. I hand it over now to Purvi to welcome the chairpersons, introduce them for the final session of the day.
Anuj, you are already intruded in Purvi's life, so don't worry about the intrusion.
Yes, this was only nominal, right?
Yes.
So with that, on that happy note, I welcome our chairpersons for the evening, Dr. Rajesh Deshmane, who is physician diabetologist and consultant diabetologist and metabolic physician from Kolhapur, and Dr. Abhay Wagh, who is again a physician diabetologist at Dr. Wagh's Diabetes Specialty Center, Nanded. Welcome, and please introduce our next speaker, who is a very, very special mentor to me.
Thank you, Manoj, and thank you, Purvi, for your invitation. So it's my pleasure to introduce Dr. Beni Neglur. She is a consultant diabetologist and physician from Dr. Neglu's Diabetic Specialty Center. As well as she is a diabetologist at Jupiter Hospital, Thane. She is visiting faculty for Diabetology Fellowship Program at D.Y. Patil University, Mumbai. She is teaching faculty for Public Health Foundation of India, as well as fellowship of obesity from MUHS, Nashik. She is also organizing chairperson for annual conference, that is Women and Diabetes, from last 3 years, almost 2017, 18, and 19. So over to you, Madam.
I'll just share my screen. Thank you so much, Dr. Dasmane. And I must tell that very talented couple, Dr. Manoj and my very, very good friend, Dr. Purvi, you're doing an excellent job by saluting the discovery of insulin and saving the lives of so many patients by having this session today. And you've heard all through this month that Leonard Thompson was the first recipient of Banting's insulin. But let me tell you, since I'm the only woman speaker in this and I'm speaking for women, that it was Elizabeth Hughes who was the first girl recipient of type 1 diabetes. She got type 1 at the age of 11. She was the daughter of the governor of New York, and she was the first lady recipient of Banting's insulin. And remember that she lived up to the age of 72, which is really great for a type 1 patient after taking 3 or 4 insulin injections per day. So that's an inspiration to everybody else. Let's see what is the effective use of insulin in Indian women. Thanks for this topic. This is very close to my heart because I deal with women and diabetes. You can see the numbers increasing, the prevalence of diabetes here, both in men and women, and it's going to be higher and higher in the years to come. But if you compare the men and women, they are comparable. For every 9 women, there is 1 woman with diabetes. And we know that we are seeing younger and younger diabetics, and the survival age is also going up because of early detection and improved diabetes management. And so the area under the curve of the number of diabetics is increasing and will increase in the years to come. You will see what is happening in India. This depicts the prevalence of diabetes per 100 women in their late reproductive ages between the years 35 to 49. And you see Kerala, Andhra Pradesh, Mizoram have the highest prevalence, 14.9, etc. And you see all the shades of red and orange, and you will see Rajasthan having the lowest prevalence, 6.4. Women are different from men besides the XX chromosome. which gives rise to the estrogen, and progesterone, which has its effect on all the tissues of the body and especially on the reproductive organs. There's also a gender issue which is economic, behavioral, environmental, lifestyle, which also contribute to the development of germ cells, the fetal programming, the newborn, puberty, reproductive age, aging, and the manifestation of diabetes, complications, and comorbidities. And women show more dramatic changes in hormones and body due to the reproductive factors during lifestyle. And you can see here the physiological differences. Men have increased food intake, increased energy expenditure, increased visceral fat, increased liver fat, increased muscle mass, low adiponectin and leptin, and women on the other side have the opposite of this. If you look at the pathological sex differences, you will see that men have an increased fasting glucose incidence, whereas women have increased glucose tolerance incidence. Men have increased diabetes incidence at an earlier age. They have an increased fatty liver, and women have an increased BMI, increased glucose tolerance, and increased obesity, but not so much of a fatty liver. They have increased depression, increased androgens, increased PCOS, and so they are different. What is it with insulin and estrogen? We know that estrogen is very important because it gives a positive effect on the metabolism, especially it optimizes the insulin activity. And premenopausal women produce estrogen, which actually controls the insulin resistance. And if you see this graph here, you will see that in the pathophysiological mechanism with sexual dimorphism, you will see that women are more insulin sensitive than men, but this sensitivity only remains when they are normal glucose tolerant. Once they have abnormal glucose tolerance, then men have more of impaired fasting glucose and women have more of impaired glucose tolerance regardless of their ethnicity. And if you look at the pathophysiology of diabetes, you will find that abdominal visceral adipose tissue is more strongly associated with insulin resistance in women than in men. And obesity and metabolic dysfunction in women decreases the inherent sex hormone protection from cardiovascular disease, to which the women have a higher risk than the men. If you look at the menstrual cycle, this is also one of the physiological mechanisms related to insulin, and that's why I put this slide over here. The estrogen progesterone which surge during menstruation also affect your blood glucose levels. And in some women who have type 1 diabetes, the hormonal changes that come with menstruation can cause changes in the blood glucose level. This is what happens in normal pregnancy. Somewhere between the 24 to 28 weeks, the insulin requirements increase markedly, right up to 36 weeks, and then they come down after that, giving rise to women who cannot manage this or who have less amount of insulin, a condition we know of GDM. Insulin is the preferred drug of choice in GDM. Although 70 to 80% respond to medical nutrition therapy, you have to combine it when insulin requirements increase. And some of the women can also be put on an insulin pump or on a pen or syringe, whatever is affordable to the patient. In pre-gestational diabetes, we know that the levels of HbA1c have to be around 6 to 6.5. You need to omit all the glucose-lowering oral agents and put them on insulin. I'll just tell you subsequently which are the good insulins to be used in hyperglycemia in pregnancy. When do we initiate insulin? You see the different guidelines here. ECOG says that when fasting goes above 95, 1 hour levels go above 140 and 2 hour levels go above 120. In addition to nutrition therapy, you have to start insulin. IDF wavers a little with the fasting. So they say any fasting level of more than 90, along with nutrition, you have to initiate insulin. Whereas DIPSI guidelines, which in the Indian scenario, we follow this, Insulin is often added to nutrition therapy when the fasting glucose levels are more than 90 and 1.5 hour postprandial glucose are more than 120 after 2 weeks of medical nutrition therapy. Mind you, we should not try medical nutrition therapy only for more than 2 weeks, but it has to be combined with insulin therapy and continued throughout pregnancy. What is the choice of insulin regimen? We normally give short-acting insulin. A prandial insulin is the correct way to start. It depends, you can give once a day or twice a day, depending on the postprandial excursions. Start with a small dose. 4 units is enough, but you can even go on along with medical nutrition therapy at a lower dose. You can give 3 units and 2 units, but multiple doses, depending on the prandial excursions, are good enough and they give an excellent control. But if the fasting plasma glucose is more than 110, then you have to give a basal. You can give a basal insulin or an intermediate acting insulin at bedtime. In those patients where basal bolus regimen is not convenient for the patient, you can give a premix regimen, keeping in mind the limitation of titration with a premix insulin. What is the choice of insulin? Which one is favorable? ECOG says insulin analogs have been used in pregnancy and do not cross the placenta. IDF says rapid-acting analogs, Lispro and Aspart, have been found to be safe in pregnancy. And the usual recommendation is to use NPH or Detamir as basal insulin, but premix insulin are convenient alternatives, but they lack the flexibility. And therefore, you have to be a little careful. NICE says that Aspart, Lispro have an advantage, but DIPSI guidelines says that it's ideal to use human insulin. They are least immunogenic. Rapid-acting insulin analog, Aspart and Lispro, have been found to be safe and effective, and they give an optimal control of the postprandial glucose during pregnancy. This is all the data that has come. Before 2015, they divided this into category B and C. You will see that all the faster-acting insulins, whether they are conventional insulins or analogs, Aspart, Lispro, and the long-acting insulins, Detamir, NPH, and the mixed insulin are in category B. The only insulins that have not got approval are insulin glulisine, which is a rapid and should not be used, and insulin degludec has not yet got the FDA approval. It is still in category C. Insulin glargine, there is a little, it's a little shaky. Although it comes in category B, they are now changing the views after 2015, and they are saying that if the woman is already on glargine and is doing well, then they can continue glargine to weigh the benefits of between and suboptimal glucose control and the insulin that is used. This is the RCT that was done in 2014 by Hord and al. And this was the first large RCT to prospectively investigate long-acting Detamir in pregnant women with type 1 diabetes. And they found that Detamir was associated with longer-term pregnancy. It also showed a better PPG fasting control and similar hypoglycemic events as that of NPH. And that is why it was approved. It is a good drug to give when the Detamir is required in large doses. You can also divide it twice a day, morning and evening. This is the RCT that was done in 2010 by Heller and al. And this has shown that rapid-acting analogs are also useful in pregnant women with type 1 diabetes. Here, the study was done in type 1 diabetes. Insulin Aspart was compared to human insulin with NPH, of course. They not only evaluated the maternal hypoglycemia control and safety, they also included the perinatal outcomes, and they found that insulin Aspart had a better PPG control, and compared to human insulin, both had similarities in maternal and neonatal outcomes. So we have now RCTs to prove that rapid-acting analogs are safe in pregnancy, and also Detamir is safe in pregnancy. We know that postpartum glucose management in pre-gestational diabetes, you have to reduce the insulin 30% of the pre-delivery doses for the first 3 to 4 days, or the rule of the thumb is 30% of pre-delivery insulin dose or 60% of the pre-pregnant insulin dose. And then depending on the monitoring, you can increase or optimize the sugars control. This is the changes in weight in pregnancy and the insulin requirements. You will see that from 0 to 9 weeks, the insulin requirements increase. 9 to 14 weeks, they actually decrease. They go down further. Requirements go down between 14 to 16 weeks. And then from 16 to 37 weeks, it actually doubles the requirements. And 37 to 40 weeks, they come down further, and immediately postpartum, they can drop to half the pre-pregnancy needs, which has to be kept in mind when we start treating our patients of hyperglycemia in pregnancy. This is a physiological graph to show the insulin requirements in men and women. You see somewhere at puberty, between the age of 10 and 14 in girls, there is an insulin surge or requirement increase. If they are type 1 diabetic, you have to step up the doses of insulin in this phase, after which the insulin requirement come down a little. In boys, on the other hand, the stepping up of the dose should be between say 13 to 16 years of age, and it remains higher than the girls. This is specifically applicable to those taking insulin at a younger age. Type 1 diabetes, as we know, in women, insulin is the therapy of choice, and it can be given in vials, injection pens, or even in pumps. This is another area where we have to give insulin. Young diabetics now are different from the older diabetics because they have lesser beta cell mass. They're usually lean. They have more comorbidities. They have increased risk of cardiovascular disease, and they are insulin requiring very early in their duration of diabetes compared to the older patients above the age of 40 and the onset after the age of 40, whose general pattern we all know of. Therefore, we have to keep these young individuals in mind because of the complications that can happen and starting insulin very early. Estrogen, progesterone in women affect how the cells respond to insulin. Therefore, after menopause, there's a change in the hormone levels that can trigger the fluctuations in the blood sugar level, and that can also give rise to glucose variability in postmenopausal women if they are on insulin. By the time they are menopausal, you see they are already on 1, 2, or maybe 3 drugs. This is the time when you have to consider giving insulin therapy. They might also be on hormone replacement therapy, and also this is the time for fluctuation, perimenopausal, postmenopausal, and therefore the insulin requirement changes. In any kind of infection in women, of course, also in men, this is nothing different in women. You have to put them on insulin, especially if they are admitted or in the ICU. And especially you saw now in the COVID era, in the first wave and the second wave, the third wave, most of them were asymptomatic and the admissions were few. But in the first and second wave, they were quite morbid patients. Hospitalization was higher. And also they were put on high dose steroids, which has totally disrupted the glucose control. And women are no exception to this. So they required insulin at that time. And any infection when they're hospitalized, those women who are on OHA have to be put on insulin. There's another aspect now of women, which is different in men. You see that in South Asian countries, the low literacy traditions such as consanguineous marriages, urbanization, they multiply the risk of diabetes. And there are so many cultural barriers which actually prevent the adoption of a healthy lifestyle and medications, especially in insulin requiring women. And these are the risk factors because an illiteracy makes a woman the slave of the family. She does not have the confidence to take decision on the treatment and make her totally dependent on others on medication intake, more so if they are on insulin. And you can see the board here held by the child. Over 250 million women in Asia are illiterate. There's also a gender equality. The belief that girls are born to serve and boys to earn and rule prevails in most of the South Asian countries. And since I have to speak on Indian diabetics, I think this applies here. In a limited income family, the boy is given better food and provided education. The girl gets poor nourishment and is made to do the household chores from a very young age. She's dependent on the male members of the family. And example, a woman cannot receive needed health care because norms in a community prevent her from traveling alone to a clinic, even during pregnancy. And also if she is on insulin. So you can imagine the socio-economic factors which actually disadvantage a woman from getting proper care and treatment because of their accessibility to insulin, especially during pregnancy, and affordability also to the medications that are required in diabetic women. So in summary, diabetes in women presents differently due to the reproductive hormone profile, fat distribution, and other metabolic changes, including the lifestyle, the socioeconomic, and the psychosocial issues. And therefore, suboptimal diabetes care during puberty and adolescence can affect the fertility, while inadequate diabetes care during pregnancy can have adverse fetal and maternal outcomes, and therefore give rise to a future generation which is already compromised in their metabolism. Management of diabetes accordingly becomes different in women and men, and healthcare professionals should appreciate the differences in women and men in terms of diagnosis, in management, in insulin requiring women, and also on their follow-up. Thank you. Thank you very much.
Thank you. Thank you so much, ma'am, for focusing on the effective use of insulin in Indian women. There are some questions. When to start long-acting insulin in pregnancy?
Normally, we start with a short-acting insulin along with nutrition therapy. When you feel that the postprandial excursions are getting out of hand and the fasting is going up, you look at the fasting glucose. If the fasting is going up, then you start a long-acting insulin in addition to the rapid insulins that you have to give for the postprandial excursions. So you need to monitor the fasting and also the postprandial in these pregnant ladies. And the fasting in pregnancy has to be pretty low. And you know, the targets have to be less than 95 fasting. So that's the time when you give a postprandial, and that's the time you give a basal insulin. And if the basal is too high, you can also divide it into two.
Okay. We had a discussion about use of metformin in pregnancy. Ma'am, what about your ways, means how you see about metformin use in pregnancy?
See, there are many guidelines. Indian guidelines also say that you can give metformin in pregnancy after 20 weeks. This is very important, the last 3 words, after 20 weeks of pregnancy. Because the MITI trial and also the MIG trials and the MIG follow-up trials have shown that metformin is relatively safe. But you see, the MITI trial that came out 2 years ago have shown small for gestational age babies. That was the only hitch. Otherwise, it has shown benefit. Metformin has done well in the pregnant ladies. And so if you give metformin too early in pregnancy, before 20 weeks, I think there will be a problem. Also, metformin is not to be given when they have other maternal complications like preeclampsia, like say hydroamnios and hypertension. And I think metformin should not be given. The only place where I give metformin is if the woman has PCOS and I continue it for the first 3 months and then I withdraw. But in the 3rd trimester, if the woman can manage with nutrition therapy and they are just borderline higher, then you can afford to give metformin to these women to decrease the glycemic variability. And secondly, if the woman is obese, in obese women, metformin does much better, but it should always be along with insulin in small doses. I give insulin even 2. I don't go to 4 units. I give 2, then I increase, and then I may use metformin in obese people.
Thank you so much, ma'am, for focusing on the use of insulin in Indian women. And thank you so much for inviting me as a chairperson. Thank you, Dr. Manoj Chawla sir, Dr. Puri ma'am. Today we have a next speaker who is a
Before you just introduce, can I just say a big thank you and really congratulations to Purvi. She's my great friend. And of course, Manoj, really you've done a wonderful job. Thank you very much for inviting me.
Ma'am, I have to thank you despite all your busy schedule as well as your preparations for WhatCon going on. You managed to sneak out this time for us. We are eternally grateful and thank you always for guiding us and mentoring us, ma'am. And beautifully chronicle journey of we didn't know the first the woman in the world who received insulin shot. So thank you again for that as well.
Yeah.
Thank you.
Thank you so much.
Yeah, today we have an eminent speaker, Dr. N.K. Singh, sir, and they are focusing on the short-term insulin use. I will introduce sir in short. Sir is a diabetologist and physician at Diabetes and Heart Research Center, Dhanbad, and sir is a chairman of RSSD as Jharkhand. Sir is an ex-governing body member of National API. And sir is also ex-chairman of API's Jharkhand. And sir is having edited Millennium Book of Medicine. And there are more than over 30 publications with the name of sirs. And sir is a admin and founder of CME India. As well as sir is an editor for the website www.diabetesdhrc.com. I welcome Dr. N.K. Singh sir on focusing the topic of short-term insulin use. Over to you, sir.
Yeah, thank you, chairpersons, and great thanks to Manoj and Dr. Purvi.
Thank you for coming.
No words to praise you for very exciting sessions, which I am already tuned since this started. You have given a very, very important clinical topic, and that is a short-term use of the insulin. I think not in there were many conferences we have heard this, but anyway, I think this will be very clinical for most of us. Let me just have the slides. Yeah, good. I think it is visible.
No, sir. So we can actually see your email. Maybe you.
Hello.
PowerPoint is.
It is visible.
So the screen is visible, but we are able to see the email box, not the slide set.
Oh, so okay, just 1 minute.
Yes, sir.
I think.
I just take this opportunity to thank Dr. N.K. Singh sir for joining us.
Just let me share again. Huh?
Yes, sir. Yes, sir. Please
no problem.
go ahead. Despite being unwell, he's managed to be there on both the days, 11th as well as 18th. Really appreciate that. And he is a powerful resource of knowledge and information, as we all know in the country. Yes, sir, we can see it.
Yeah. Thank you, Purvi. So this is a very, very important talk, I will say, that you have chosen and given me to. That is the short-term insulin use. Insulin, we have the great journey, which we are celebrating now, a century since its discovery. And there is nothing to tell that the mainstay of therapy in type 1 diabetes is insulin, insulin, and insulin. But many times, available option for many patients with type 2 diabetes, and in many situations where insulin becomes so important. So our learning objectives will be the very unique concept of short-term therapy in many newly diagnosed cases. And now it is known as the STIIT, that is the short-term intensive insulin therapy. I think already we have lots of discussion on the GDM, where again it is a short-term therapy. post-COVID. Again, there will be a talk later on, so I think I will not go much in that, but that is also a very, very important area where we have using insulin in the steroid-induced hyperglycemia. So insulin use in perioperative is well known and very important. And in hospitalized patients, in many conditions, we use insulin. So when you get a high blood sugar at diagnosis, suppose a newly detected diabetes has come to you and there is high blood glucose, what you do? So that is a very important discussion. There is some new research also coming where this has been shown that if you use a short-term intensive insulin in such cases, the long-term effect of intensive insulin treatment has been tested in several studies and had been shown to improve the beta cell function and restore early phase insulin secretion. And this is very, very important. So this is defined as insulin administration shortly for only a brief period of time is an alternative concept and aiming to entirely revise the perspective of diabetes management. So even in type 2 patients, where if you see that there is early introduction of insulin might be needed, or rather needed, if there is a evidence of ongoing catabolism, this whole much of the weight loss, symptoms of hyperglycemia is present, and basically the HbA1c more than 10% or blood glucose levels something around 300, these are very, very high. So in such conditions, although in most of cases, our practice is not to start insulin even in such a scenario, and there are so many factors, that is not the science, but that is the patient factors, insulin fear factors, and many factors. But the standard of care says that it should be started. So this SIT treatment is recommended even for now the treatment of newly diagnosed type 2 patients to eliminate the glucotoxicity, to reduce the beta cell overload, and to support the residual beta cells and to enhance the insulin sensitivity. So this is very, very important. You can see the short-term insulin therapy can successfully lay foundation for prolonged glycemic control. And what happens here? The pancreatic alpha cell dysfunction may contribute to the metabolic dysfunction found in diabetic states. So remember, this is we are talking about the alpha cell dysfunction. And because postprandial paradoxical hyperglucagonemia leads to the elevation of blood glucose levels. So this SIT therapy may also improve this alpha cell physiology. And indeed, it is possible that a stepwise addition of insulin leads to the reduction of this hyperglucagonemia. So this is very, very important concept coming. What could be the pros and cons? Like if you see in such scenario, evidence from the clinical studies, they achieve and sustain prolonged remission. It has been shown in many studies that you have given a SIT therapy for a short period and you get a prolonged remission. And there could be potential mechanism like the de-differentiation of beta cells, redifferentiate to mature beta cells after insulin therapy, and there we have got evidence also. And when there is lower baseline fasting glucose, higher BMI, better early phase insulin secretion, lower exogenous insulin requirements, shorter duration of diabetes, such patients really do very much better. And this also, there is significant improvement in the quality of life. And so if you think about the cost, when there will be an improved beta cell function, that could result in better long-term glycemic control and health. So my urge is that in specific such situations, think about the SIT. Because this is also now the ADA recommendations that initial therapy has the advantage of being effective, where other agents are not should be considered as a part of any combination regime. So when the hyperglycemia is severe, I told, the catabolic features are there, weight loss, TG is so much high, there is ketosis are present, then definitely you go for the insulin. So this is also a very important thing. So I think my first part is this, that there are lots of benefits of SIT, and the short-term intensive insulin therapy appears to me a very good option for at least some patients in the type 2 diagnosis, type 2 diabetes cases. And although there are many predictors where they will respond to the short-term intensive therapy, I am just showing here what are the predictors, but you can still see here that this is a very, very nice concept and filled with science. The second part is that the management of the hyperglycemia in hospitalized patients is a short-term affair, definitely. And there are lots of complications, comorbidities. Well, patients could be in a new diagnosis or diabetes and pregnancy or acute diabetic emergencies, like some complications, some device-related problems is coming, or general diabetes management, or admission unrelated to diabetes like surgery. So type 2 patients in such conditions, only insulin you have to give. And there is a way how you start that hospital management of diabetes. Can shorten here if you start insulin, the hospital stay, reduce the need of readmission, improve the patient outcome. Remember, I think this is a busy slide, but anyway, this is how the non-critically ill patients we treat and the critically ill patients when they are hospitalized. And I'm not going to saying you all the details, but basically the regimes are like the considered low dose basal insulin, or OADH when there is mild, that is known as less than blood glucose 200, or if there is moderate, they say this is from the Lancet Diabetes and Endo, that the moderate hyper is 201 to 300 and basal insulin with or without correction. Or if there is severe, then definitely you go for the basal bolus. There is no choice. So this is how this is summarized, that anti-hyperglycemic insulin recommended. Critically go for IV, but non-critically you can go for SC insulin. And you know the targets for starting insulin, I told. And the target of suppose 110 to 140 may be appropriate for selected patients. And if this can be achieved without significant hypo. But higher glucose ranges may be sometimes acceptable in terminally, if the patient is terminally ill, there is severe comorbidities, or when the close nursing supervision is not feasible. So you see here, but what about the sliding scale insulin? This is, I think, very exciting concept. But these days, in anti-hyperglycemic treatment in hospitalized patients, non-ICU, the sliding scale insulin is strongly discouraged. You can see we have the trials like Rabbit-2 trial, where you can show you that if they were compared with the this SSI, that is the sliding scale insulin, and here you can see where the blood glucose target of less than 140 was achieved in the 66% of patients with the glargine and glycine group, and only in 38% if you are going for this SSI group. So this clearly shows that sliding scale, we are not getting the desired things. You can see here it is much better here with the basal bolus and not with the sliding scale insulin. Even you can see that the glycemic control rapidly improved after switching to the basal bolus. You can see here. So here the message is that the basal bolus insulin regime is preferred over the sliding scale insulin in the management of non-critically ill hospitalized patient with type 2 diabetes. You don't, because if you give this sliding, you can see here there is you have a scale, you know the insulin level, sorry, blood sugar level, and according to the scale you give the insulin, then there could be a roller coaster effect of insulin and lots of variability problem you can see here. So I think this should be quite clear. And then definitely in most of the situations, we go for the basal bolus and the correction. So this is how it looks like, and how we give this basal bolus in insulin naive patients. I think the dose should be remembered, the total daily insulin dose 0.3 to 0.5 units per kg, and you have calculate the total requiring dose, and then half of the total daily insulin dose is allocated to basal bolus dosing, that is 1 to 2 times daily, another half to rapid acting insulin derived 3 times daily before meals. So this is quite simple. And definitely I showed you the superiority over the SSI. So I'm not going to hear details. This shows the how to calculate and what are the dosage that is available everywhere. And remember also that for the short term, you may need the insulin infusion in at least uncontrolled diabetic, stress infections, cardiac surgery, transplant surgery, labor and delivery time, high dose steroids and requiring dextrose content infusions. So certain conditions, apart from all those basal bolus and SL scaling, you have to straightforward go for the insulin infusion techniques. Now, after the COVID and now again it is going on, this insulin used in steroid-induced hyperglycemia is very, very important discussion. Dr. Suya will tell you more details, but definitely in such situations, although many cases I have seen they have used with the OHA, but there are benefits of insulin for the short term, definitely in such cases. There is immediate onset of action, the easy titration, unlimited efficacy, greater flexibility and predictability, and rapid ability to target postprandial hyperglycemia, and dose can be modified related to patient oral intake. But definitely, this becomes a very attractive choice. You can give basal bolus insulin or basal analog insulin or multiple daily injection regimes according to the whatever the situation is, what type of a steroid you are using. But remember that the insulin dose must be adjusted every 2 to 3 days with increase or decrease around 20%. And insulin dose should also be adjusted based on the changes in steroid dose to prevent hyperglycemia and hypoglycemia. And percentage of insulin adjustment corresponds to half of the percent in the steroid changes. For example, if the steroid dose is reduced or increased by 50%, the insulin dose will be reduced or increased by 25%. So this is how we think about that. So definitely this is a very, very important issue these days. And what general recommendations for the steroid-induced hyperglycemia you are saying here. So this is already endorsed by ADA also. But just I will say here that to control the fasting plasma glucose, use a basal insulin like glargine or NPH. And glargine works for 24 hours, dose either in the morning or at night and taken at the same time daily. But remember the NPH, which is a very attractive choice, works for about 12 hours and dosed twice a day if 24-hour coverage is required. Or if the patient has a morning steroid dose with rising glucose is basically post-lunch, NPH can be given in the morning peak of NPH to coincide with the rise in blood glucose levels. So if the patient shows hyperglycemia both during the fasting and after all the 3 meals, then basal bolus insulin therapy is indicated and glargine is given once a day to control the fasting plasma glucose, and the rapid acting insulin given at the meal time to cover most of the postprandial spikes. I think this slide is very important, and this tells you everything how to choose about the short course insulin and which insulin. And that I will not go for calculating the TDD. Monitoring is very important. And so advice even after in such cases, I should be quite clear for the such cases. So I will lastly tell here that the steroid-induced hyperglycemia, insulin is the therapy of choice, and long-acting basal insulin and basal plus insulin regime is the effective clinically proven option for achieving optimal glycemic control along with fewer hypoglycemic events. And at this point, I think this is the insulin used in perioperative management of hyper is very, very important issue. And the preoperative assessment is very important, you know. And once the surgical candidates begin to fast prior to their surgery, it is essential to stop the prandial mealtime insulin and continue only their basal insulin therapy. So this is the preoperative management, and alternately all subcutaneous insulins may be discontinued and substituted instead with IV insulin infusion in order to have a more real-time glycemic management. And patients with blood glucose concentration greater than 180 while awaiting elective surgery should receive a continuous IV infusion to maintain their glucose concentrations before 150. Although they are showing you about the IV, but I don't think practically we are following it or not, because in most of cases many other ways are there clinically which we do. But anyway, the intraoperative management, the target perioperative blood glucose level depends upon the duration of surgery, invasiveness of surgical procedures, type of anesthetic techniques, and expected time to resume oral intake and routine antidiabetic therapy. So when subcutaneous insulin is used in the preoperative period or operative room to treat hyperglycemia, blood glucose testing should occur at least every 2 hours. And this is how I'm saying you about the here it is insulin infusion is very, very important. Now the CGMS can be instituted for better monitoring if possible. And this slide is again important. I think I will take 1 or 2 minutes more. That there is emergency surgery, a certain timing and amount of the last basal prandial dose of insulin and oral hypo, and check blood glucose, preoperatively treat per recommendations below. And if, as I told you, start continuous IV insulin infusion, and for the elective surgery, follow the preoperative oral hypo and insulin guidelines for day before the day of surgery, then check the blood glucose in pre-operative area, treat per recommendations below, and if it is critically ill or duration, here you can see for operation time is more than 4 hours, then yes, go for continuous, or there is no subcutaneous insulin dosing can be given. Even the post-operative management is a short-term insulin again. If a patient is motivated to a non-critical setting, then a basal bolus or a basal plus is recommended. And the reducing the total dose by 20 to 25 gives you the starting in patient dose of basal insulin, what the percentage NPO. So reduction in basal insulin reduces the risk of hypo, particularly in those with the poor or uncertain calorie intake. So you can see how we do with the minor surgery and the major surgery and avoid hypoglycemia. So the message here is that it is essential to start insulin therapy for patients getting admitted for surgery with persistent hyperglycemia with basal bolus regime or IV infusion. And pre, intra, and post-operative hyperglycemic management is crucial for patients undergoing surgery, both elective and emergency. Last part is the role of optimum post-meal glucose control in improving the GDM outcomes, as already lots of discussion has been done. So I'm not going details for how you start insulin in GDM. Everyone, I think if you have heard our great speakers, the dosing is quite clear. Insulin dosing in pregnancy, in first trimester, second and third trimester, and choice of insulin has been also discussed very well. And it is always preferred to start with the prandial insulin, or starting dose. I am showing you the 4 units can be used for prandial insulin. Or if the fasting is more than 110, it is preferable to use a basal intermediate acting insulin at bedtime. And premix is less desirable due to limitations in titration. So I think insulin, these things that do not cross placenta already discussed for the intrapartum management. And if you think about the fast acting clinical part versus insulin part, you see that the insulin part is a one insulin which gives us or we have used extensively in the such cases of JDM.
It's time, sir. It's time.
So I'm just last slide. It is a progressive disease. Short-term insulin therapy might be beneficial in some patients, such as newly diagnosed with very high blood glucose levels. And basal bolus insulin therapy represents the treatment of choice, and short-term intensive insulin therapy is very, very important discussion. Thank you very much. So just I will end here sharing. Thank you very much.
Thank you, Dr. Singh, sir, for your nice presentation on initiation of insulin and insulin use in short-term use of insulins. So I think, sir, your comment, final comment.
I think Manoj can give the better comment.
So I think it was completely comprehensive, the entire take on short-term insulin use, covering all the aspects. So Dr. Singh, thank you so much for taking us through all those clinical situations where short-term insulin use is relevant, including what needs to be done around the operative time. So thank you. I think we'll move to the last question, and in case we have some energy after that, we will take more questions after that, but we move to the final one. Rajesh, we can move, right? Thank you.
Thank you very much. Thank you very much.
Thank you, sir.
Thank
So
you.
it's my pleasure to introduce Dr. Samit Ghoshal. So I think we always listen him in all the best possible conferences everywhere. He's a consulting physician, diabetologist from Kolkata, highly qualified diabetologist and endocrinologist. He has graduated from Calcutta National Medical College and post-graduated from Chennai in internal medicine. So he's practicing in his own clinic at Nightingale Hospital, Kolkata. He's always have special interested in diabetes and endocrinology. And we are listening him for last almost 7, 8, 10 years in all the big conferences. And definitely, so even if we are late, but it's pleasure, always pleasure to listen Dr. Samit every time. So over to Dr. Samit.
Thank you, Rajesh. I'll just share my screen. I hope it's visible.
No.
No, not
yet. Actually, Ritu, you'll have to stop sharing so that Dr. Ghoshal can.
I think.
Ritu.
Somebody from the backup, can you stop, Ritu? Yeah, can you stop sharing the slides so Dr. Ghoshal can share?
Yes, I
Yeah. And for all those who don't know, Dr. Samit is a very sharp mind and a great researcher and is highly published as well.
And he has a nice haircut also.
Got rebuked by my mother just a while back. Thanks, Manoj, and thanks, Puvi, for inviting me. Are my slides visible now?
Yes.
Okay. Thank you, Rajesh, for your introduction. It's a cricket season. I'm feeling like the night watchman, so I'll try to play as cautiously as possible. It's a very tricky topic, COVID times, and how to deal with insulin. Whenever it's an acute scenario, you always remember our good old friend insulin. And when it's not acute and a chronic scenario, then we start bringing in CVOTs. That's the latest fashion, I think. So I'll go into the bit of the thing on diabetes and COVID before right away delving into the insulin, when, which, and how. These are a few backgrounds. Let's remember there's a lot of things which has been going on and a lot of scaremongering on diabetes and COVID. The direct correlation is not as strong, but if you have uncontrolled diabetes and hyperglycemia in the backdrop and you develop COVID, especially a severe COVID and you get admitted, then obviously there's a threefold higher mortality. But doesn't mean that you have a well-controlled diabetes and you contract COVID, you have a much higher risk compared to your non-diabetic counterpart. That part is still quite wishy-washy, but definitely if you do not have very good glucose control, you might land up in trouble if you develop severe COVID. And that's obviously amplified by the fact that we see the majority, about 88% of the patients who were hospitalized, that we have the prevalence data, had diabetes in the background. And in the backdrop of uncontrolled diabetes, near 1 in 10 diabetic patients with COVID normally dies in 7 days, in contrast to the non-diabetic counterpart. So this is something we need to keep in the back of our mind. And then there is a circular relationship between the two. Obviously, COVID, there is a question mark, no direct relationship, but there seems to be some data accumulating that COVID directly can impact and damage beta cells. And thereby, by infection per se, as well as by damage to the beta cells, it can aggravate hyperglycemia. And hyperglycemia, by aggravating inflammatory response, can augment the COVID-related inflammatory damage. So they complement each other, and especially in a hospitalized environment where there are many other factors which are waiting for their opportunity to join in and worsen your inflammatory response. So we need to be very careful because we remember that most of the COVID-related management are symptomatic and supportive. But what we can do is a lot in our diabetic patients by taking care of the hyperglycemia. So first thing, we need good glycemic control that will reduce the risk of infection in those who are not yet infected, and also will reduce the risk of morbidity and mortality in those who are infected. And for that, we need frequent monitoring, and not only in those who are admitted, but even those who are at home and do not have good glucose control. And in this scenario, unless the pandemic ends, needs frequent monitoring and up titration at a much faster pace than what we are normally used to. We need to stabilize the backdrop comorbidities, because those are the ones which increases the risk of fatality or in the backdrop of severe COVID. So we need to reinforce lifestyle modification. It's most likely that patients are going to listen to us in this backdrop when they are really scared of what might happen. It also opens up a window of opportunity for us to have more dialogue, and they'll be more receptive as far as listening to you, and we can bring in a lot of changes in the exercise and nutrition part of a patient. Not necessarily everything depends on pharmacotherapy. Now let's right away go into insulin. It's not that there is no oral drugs. Yes, those who are well controlled on oral drugs, we just need to keep them on and not switch them over to insulin. But those situations where we require insulin, we must remember that in the outdoor patients who are not in good control with multiple oral drugs, we need to put our foot down and stress on initiating insulin in them. And they might be more receptive in this environment compared to the non-COVID scenario, where they used to say, give us a little bit more time. Whereas in hospital is an easy scenario, but we need to remember that we need to be very aggressive in the hospital in managing hyperglycemia. And very aggressive doesn't mean being so aggressive as to induce recurrent hypoglycemia, because then that takes away all the advantages that we have as far as managing hyperglycemia is concerned. This is a beautiful overview of which was published in Lancet of what we should keep in the back of our mind, and not specifics, but an overview. As far as the outpatient department is concerned, the main objective is prevention of infections in diabetes. And that can be done by sensitization of the patients. Optimal metabolic control can be done, choosing the current therapy and optimizing the current therapy. Doesn't mean you just discontinue everything and put everyone on insulin, but you can optimize. If they're very close to target, you just need to increase the dose of one of the OHs, do it. But increase the monitoring, because they might decompensate very fast in this current scenario. We also have the advantage of telemedicine. A lot of us are using and connecting to our patients through telemedicine. So probably it's time to increase the frequency of communication with our patients, unlike in the past when we used to give them a longer follow-up plan. Intensive care and patients who are admitted here, from the diabetes perspective, the main thing is to prevent acute hyperglycemia and related complications like DKA or HHS. That's the first thing. Adequate hydration, good insulin therapy, and prevention of infection are the three most important pillars of managing our patients who are admitted. Although this particular guideline seems to be extremely aggressive from the glucose point of view, as a rule of thumb, I think we should remember 100 to 180. Any glucose value of patients who are admitted is a very good target if you can achieve that. Remember, in COVID background, there are a lot of iatrogenic factors which can actually aggravate the sugars. And even this liberal values, as I told you, 100 to 180 might be very difficult to attain. So the outdoor management, if the patients are not controlled on maximized oral drugs, initiate basal, be very aggressive. It's not working, go for basal plus and premix. Rarely we do need basal bolus in the outpatient management, but if required, this is the time we need to be aggressive and even consider basal bolus in them. So for indoor management, first is monitoring, detection of unknown diabetes, which a lot of them will be caught up in this scenario. HbA1c becomes a good important tool in doing that. Managing non-diabetic hyperglycemia, even their insulin has a very important role to play. And then initiating or up-titrating the dose of insulin. And then definitely tackling steroid-induced hyperglycemia. So I'll be just stressing more on this part, because this is a very tricky part as far as managing hyperglycemia is concerned. Now, this is the Government of India Ministry of Health guidelines, which are available with us. It's just there online. Anyone can approach and see what's written out there. Step one, anyone who is getting admitted, whether known diabetes or not, needs a random glucose plasma glucose to be done. And if that is high, then we need to perform pre-meal and or post-meal. I think pre-meal is more important in the hospital scenario. 2 hours post-meal is extremely difficult to time. So pre-meals are easier to time in the hospital scenario. At least a 4 to 5 point SMBG needs to be done in most of the patients who are at least detected with hyperglycemia and or diabetes. Next day morning, you can get an HbA1c done. I do not know why next day morning, because it's a random test. If you have a high CBG, you can immediately get it done. Because it's a random test. Anyways, for those who are detected, step 4 and 5 tells you that you need to decide on how frequently the glucose needs to be monitored. This, I think, needs to be individualized. The pharmacotherapy part is this, I think, is too high a target. They have set more than 250 use of random sugar. I think they should be 200 according to all international guidelines. Pre-meal, again, more than 150. I don't know where these values comes from, but anyways, this is a local protocol you can always develop in your hospital. Even for the insulin part, you see it's a flat insulin, which is NPH. in those who are on steroid. And this is the part which I'll be just stressing upon before I end. Remember, steroids definitely includes glucose, but there are different types of steroids, just like there are different types of insulin. There are short-acting steroids, intermediate-acting steroids, and long-acting steroids. And so we have short-acting insulin, intermediate-acting insulin, and long-acting insulin. So we need to tailor this accordingly. For generalized guidelines of insulin therapy, I think this guideline does an excellent job. For majority of the patients admitted to the hospital, there is no substitute but giving them a basal bolus therapy. If they are not on steroids, they do not have significant baseline hyperglycemia, at least 0.5 to 0.6 units per kg body weight is the total daily dose of insulin, split into 50-50, 50% basal, and the rest 50% split into the 3 times meal, and then give them correctional boluses to take care of the additional spikes post-meal. This requires a little bit of a pragmatic approach because I think those nuances are absent from this particular government guidelines. And those are the slides I'll be showing you. A beautiful data from or recommendation from Nikhil Tandon and their group. And as I was telling you, around 120 to 180 is a very good target that we can achieve. Is achievable, and I think is safe in most patients who are admitted. Also, let us remember that most of the patients will be requiring a total daily dose of insulin in excess of 0.5 units per kg body weight because of other factors joining in. And per 50 milligrams per deciliter or 40 or 30 or 20, depending upon the baseline requirement, this is the correctional factor. So you need to give 1 unit for example, every 50 milligrams per deciliter above target in those who are requiring less than 0.5 units per kg body weight. And they give us a specific indication that if you're giving a basal bolus therapy and the daily dose requirement of insulin is going beyond 2 units per kg per day, then that's probably there's no need of further up titration. We can straight away go into IV insulin. Remember, we don't have much time. This is an acute stage in the hospital, and it's also a matter of life and death. This is the part I'll end with. Please remember, it's a type of steroid we use, and that is very much simplified by the guidelines because most of the COVID guidelines are asking us to use dexamethasone nowadays. But depending upon the steroid use, if you use hydrocortisone, it is short-acting, so they have a short spike. Within 6 hours, it dies down. So it's better to use rapid-acting insulin out here to take care of the spike. So if you're giving hydrocortisone twice daily, 2 shots of short-acting insulin are going to do a good job. Yeah, basal can be added to take care of the fasting sugar, which will be required in patients who have a background diabetes. And remember, basal, a little dose of basal is always required to cut down the risk of decay. So it's not that you use a prandial insulin and don't give a basal. It complements them, but the main requirement for cutting down the steroid-induced hyperglycemia using a short-acting steroid is a short-acting insulin. Intermediate-acting steroids like prednisolone and methylprednisolone will have a duration of action with 12 to 16 hours. You need intermediate-acting insulin. Maybe NPH will be a good choice here. If you give it twice daily, sometimes methylprednisolone, 2 shots of NPH is good enough. Long-acting, which is the drug of choice in COVID, if you give dexamethasone, you see it has a long protracted action, and probably a long-acting basal analog will be a better option. And this is what the guideline tells us clearly, beautifully, this particular data. You see here, short-acting steroid, rapid-acting insulin analogs, intermediate-acting steroid. You can give them NPH once or twice or thrice daily, and you have a slow peak and a long duration like a dexamethasone. You can use glargine, detamir, or even placebo, or even U300 glargine. So to conclude, insulin is the most important anti-hyperglycemic medication for management of hyperglycemia, especially in COVID times. So both in outpatient department as well as in hospital. Outdoor glycemic control should be intensified, not necessarily with insulin, even if with oral drugs if possible. If not, definitely we should not waste time or procrastinate while initiating insulin, which should be as proactive as possible as a preventive strategy. Indoor management hinges primarily on basal bolus regime. And to reduce the glucose fluctuations, second generation analogs can be preferred, especially in those with high risk of hypoglycemia, especially those with organ dysfunction in the backdrop. And steroid-induced hyperglycemia needs a case-based approach depending upon the type of steroids which you're using. So we need to remember that. Thank you very much for your patience here.
Thank you, Dr. Samit, for your clear-cut and crisp presentation on insulin uses in COVID scenario. Actually, the choice of steroid and the choice of insulin matters a lot. So, Manoj bhai, any questions?
I think there are questions in the chat box for both the speakers, and Samit, thank you for that precise talk on insulin in COVID, and I think one of the things that you did, which very often gets missed out, is differentiating between the steroids, and that's important. In general, the larger talk is on use glycoside, use NPH when it's steroids, but clearly that's changing. What was not included in your talk was the impact of deflazacort. Now, again, not the steroid of choice for COVID, but that has been used, and we know the impact on glycemia is much lesser. Any thoughts on that? That's one question to you. Your aspect on using short term, I think, was also mentioned in last week's conversation when we had Dr. A.K. Das also with us, and he said he's been using a lot of FIASP, so to say, in short term and has had good success. So your thoughts on both these aspects?
I think the first part you're absolutely clear, because most of the pulmonologists nowadays are using Defcort quite frequently because of lesser metabolic derangements, and that's where probably we can even get away with OHS without introducing insulin. So that's a better insulin to use in backdrop of COPD. FIASP, I'm not very sure, because you see it's actually going for around 6 hours. I think the conventional rapid acting would be, or even a short acting would be a better choice, because I don't need a rapid off, because I need at least to cover for 6 hours. So that is a bit tricky out here.
No, that's fair. That's fair. Yeah. And if Dr. N.K. Singh is still with us, sir, there's a question in the chat box which is asked, and if Dr. N.K. Singh is not there, would request Sumit to take it. If Dr. Singh is there, it would be wonderful. There's a question on short-term use of insulin in hospitalized patients during COVID who are non-diabetic. So that's a question for both of you. Dr. N.K. Singh can take that about short-term use for non-diabetics.
Basically, he's referring about the new onset diabetes.
Or just stress hyperglycemia.
Or it could be a stress hyper, or it could be a steroid induced also. So you have to differentiate what is the problem. Otherwise, it is very important that you maintain the euglycemia. Maybe it depends on the level of the hyperglycemia. Suppose it is just varying a bit from the normal range, then you can manage with something like some drugs also, if it is depending on the whether the patient is moderate or severe. Otherwise, definitely a short-term insulin will be very beneficial, and we have used, and it has been used everywhere, the short-term insulin with the fast-acting insulin. I think that will cover prandial or as corrected insulin, you can do that. So I think there is no harm in giving, no harm, rather it is indicated in such situations.
Thank you. Thank you. Are there any more questions? If not, let's thank both the speakers and Dr. Benny Neglur, the last 3 speakers who've done a wonderful job in these clinically relevant topics. Thank you both the chairpersons for this last session, Dr. Rajesh Deshmane and Dr. Abhay Wagh. Thank you for joining us. If there are no more questions, then we move to the final thank you from our side, and we have Dr. Ashna Patil, who will be offering the vote of thanks. Ashna is a consultant diabetologist at the Tunga Hospitals, Mumbai. Over to you, Ashna.
Thank you, sir. Hello and a very good evening to everyone. As all good things come to an end, we are ending this lovely symposium on insulin time travel, which has been so well and accurately planned and executed by Dr. Manoj and Dr. Purvi ma'am on completing exactly 100 years of insulin. We have had excellent topics of discussion today and so much of learning. And it is my great honor and pleasure to get this opportunity to thank all you dignitaries. On behalf of the Mumbai Diabetes Care Foundation, I would like to express my gratitude to all the esteemed speakers of today's session, Dr. Banshi Sabu, Dr. Sanjay Reddy, Dr. Jyoti Dev, Dr. Sunil Gupta, Dr. Anuj Maheshwari, Dr. A.G. Unnikrishnan, Dr. Mangesh Tivaskar, Dr. Benny Neglur ma'am, Dr. N.K. Singh, and Dr. Samit Ghoshal. Thank you, Dr. Purvi Chawla ma'am, for moderating the panel discussion so well. Also thanking our dynamic chairpersons for the evening, Dr. Amit Rajput, Dr. Sheetal Avarsikar, Dr. Rahul Dope, Dr. Anushri Mehta, Dr. Mahendra Patel, Dr. Dhananjay Mane, Dr. Rajesh Deshmane, and Dr. Abhay Wagh. I would also like to express my gratitude to all the delegates for their lovely presence and contribution in making this webinar a great success. Last but not the least, thanking all the sponsors involved in the success of the program, namely Sanofi, Novo Nordisk, Biocon, Cipla, and BD, And to the organizers, IJCP and RX events, thank you. I thank each and every one of you once again for participating in this centenary celebration and making it such a huge success. I hope you all take care and have a good night. Stay safe. Thank you.
Thank you. Thank you, Manoj.
Fantastic. Thank you once again, all of you. It has been really overwhelming and a very, very interesting 2 weeks that we've had.
Thank you. Thank you, everyone.
Thank you.
Bye.
Yes, and thank you for staying with us. I know it's late. I'm sure most of us are hungry. Some are thirsty as well, but yes, sure. Thank you so much and hope to see all of you soon on some such similar platform as we plan more and more academic sessions. And a big shout out and thanks to everybody involved in this. Thank you so much. Have a wonderful evening.
Thank you, sir.
Thank you.
Well done,
Thank
team.
you. Thank you.
Thank you.
Good night.
Thank you.